We good?
Yeah, these are good. They're scrolling through just fine.
Okay.
All right, so I think that's looking good. Is there still a bunch of snow on the ground?
So we had 2 feet of snow, and then we had kind of a warm, drizzly day, and a lot of it went away. And then last night we had freezing rain all night. So there's an inch of ice everywhere. It's
Oh
pretty
boy.
nasty.
Yeah, that is pretty bad.
So it is what it is. I mean, it's been an incredibly dry winter. We only had one other occasion all winter where we had to shovel, and so it was a lot of shoveling on Friday and Saturday. But last whenever that was that it fell Saturday and Sunday. But that's it for the whole winter. So
Yeah,
it's been I can't complain.
yeah. I saw videos of people skiing down the streets in Beacon Hill after the snow.
Yeah, yeah, that was impressive. 2 feet, and to Boston had 30 inches, which I think is the biggest one-day snowfall on record.
Yeah, that's a lot. Um, oh, Chris, for time warnings, what's the best way? Do you have a timer over there by any chance, Dr. Rose?
I have I have something here that I will keep track of.
Okay, that sounds good. Do you want us to text you with time warnings? Is that helpful at all?
I don't mind if you do it, but when I'm talking, I don't have the chat window open,
Yeah,
so I won't necessarily see it.
see those. Okay.
I will try hard not to run over. And one of the things I'm going to announce at the end of both talks, I'm going to at the end, I'm going to just put up my email address.
Yeah.
A lot of the interaction after I give a talk is at the coffee break or at lunch, and I'm not there to do that.
Yeah.
So I'm going to post my email, and you should feel free to, I'll try to remember to announce it, that if anybody wants my email, to just ask you. And if they have any
Yeah.
questions, they can just write to me about it.
Okay.
I'm happy to have discussions about this, but this long distance format doesn't suit it very well.
Yeah. Yeah. All right. Well, that sounds good. What else? Anything else we need to check on? I think we're looking.
So you're not getting any little echo or vocal kickback or something when I'm talking?
No, you're sounding good over here.
All right, fine.
I think it's looking good, Chris. Anything else? All right, sounds good. Okay.
So what happens when I finish? Is it immediately another speaker, or you have coffee break at that point?
Yeah, we've got a couple speakers after you, and so what we'll do is we'll do your talks, and then we'll have a time for some questions, and then we'll switch over to another talk, and that speaker, Dr. Kaufman, is going to use her laptop, so we'll probably lose you on the Zoom at that point,
Okay.
and then I suppose if you want to join back in at well, probably not. It probably would be pretty challenging to.
Yeah. What I'm inclined, if I can keep the timing reasonable, to take a couple of questions after the first talk before I do the second talk, instead of just blasting through and saving questions to the end.
Yeah.
That'll depend a little bit on me being concise, but I'll try.
Yeah, that sounds great. I was going to introduce both talks at the beginning and then let you just transition
Fine.
as you.
Great. Well, but I may take a pause for a couple of questions just because they're kind of different.
Yeah, perfect.
Okay.
All right.
So what else is new? How's your practice?
Practice is going well. It's the otology side has built up pretty nicely. The skull base side is still fairly light, and sort of as expected. We didn't have a skull base neurosurgeon for a little bit, but we've got 2 of them now, so I expect that to probably ramp up a bit. But the practice and the work side is really good. We've got a really good group of people out here that we work with, and so that makes it fun.
Good. That's nice.
Yeah, I feel like
Did you get any of this storm that just hit?
Do we get any snow here that sticks?
Yeah. I mean, I saw that Mexico got some bad weather. Did it reach to you?
Yeah, not well. I mean, it's relatively chilly here, but I mean that means sort of highs in the 50s during the day.
Right.
It's kind of a big deal when it gets below freezing for the low in the middle of the night, because a lot of the vegetation here is sensitive to it. So that's our That's our version of bad weather.
Yep.
So
Yep.
yeah, it's chilly. We had a dinner last night for the faculty, and it was outside, and it was probably in the high 40s or low 50s, and I was breaking out my ski hat and considering wearing a winter
They
coat.
have salamanders, the radiant heat, propane heaters over you or
Yeah,
something
actually
to
there were a
make it.
bunch of heaters, and so it was actually pretty comfortable. But
Yeah,
it's kind of amazing how much you acclimate.
you acclimate.
Yeah, right.
Yeah, my wife and I are busy renovating a house in California for our end game.
Oh, really? That's exciting. Where in California?
In Claremont.
Okay.
It's a little college town about
Yeah.
40 miles east of LA, right in the foothills of the San Gabriels. It's where Lisa grew up, and we
Ah.
inherited her mom's house there about 10 or 12 years ago, and we just inherited her dad's house, and his is bigger and nicer, but it needs a lot of work. So we're going to take the next year or two to get it to our liking, and then probably move there. So we'll see.
Wow. Very exciting. Do you guys have a rough time frame for when you might move out there?
I would say probably 2 to 3 years is the target. It could be closer, it could be farther, but I'm guessing 2 or 3 years.
Wow. Very cool.
It's a soft target. Lisa has a job she likes, and I have a job I like. We're not running away from anything,
Yeah.
but if the grief to glory ratio gets too high, we're ready to pack. And over the last few years, at least for what I do, the department has evolved to a point where we have quite a robust and growing vestibular division. We have two ENTs, me and Matt Croson. We have two neurologists. We're training up another neurologist. We have another ENT guy arriving in the fall who is from Europe, who's just a medical dizzy doc.
Oh, wow. Okay.
And more, sort of 75 or 80% research and part-time medical dizziness. So we have a lot of people, and if I sneak out the door, nobody's going to notice. So that'll be good. I'm not going to be leaving a clinic full of dizzy people with nobody to take care of them.
Yeah. That's great that it's grown. I haven't met Matt personally, but is he mainly clinical or a split or
It's a split. He's kind of 50-50 or 60-40 or something, but he's a split. He did his residency at Duke, but he's Canadian. He went back to Toronto for his vestibular or neurotology training, and now his background. He has a degree in bioengineering, and he's done a lot of artificial intelligence, machine learning stuff, and so his research is in that area. And he's actually taking an AI fellowship right now, kind of part time, while he's doing his research stuff.
Oh, interesting.
Um, his hope was to have a neurotology practice that was skewed toward dizziness, but still with a fair amount of surgery. He's been here coming up on a year and has really not managed to get surgery going to speak of. We have too many hungry surgeons,
Yeah, that's
and I think we're not, we're encouraging to keep the door open for a surgical practice to slowly develop. But between his research commitment and a clinic full of dizzy people and tinnitus patients, he feels like he hasn't operated hardly in a year. He's not going to be able to keep up his proficiency if that doesn't materialize. He is resigned to being a medical doctor. He doesn't seem heartbroken about it, but
oh
it's
yeah.
not. It wasn't what we hoped for when we recruited him.
Yeah. Yeah, there's certainly a lot of other neurotologists out there that you have to compete with to try to get those cases, and especially with the young people on faculty. Like, I mean, Dave's been there for a little while, but Elliot and Dunia,
Right.
and
Yeah. Well, what I figured the way we started things out is that I would send him everybody who came to me who needed surgery for, whether it was the labyrinthectomy cases or the, chronic ear revisions or the cochlear implants. And so that's been the plan. But for him to get credentialed, which dragged on, and then he doesn't have block time because he's such low volume. You know, it takes him a very long time to get OR time.
yeah,
And and between that delay and his own schedule because of his other research and training commitments, he's not actually very available,
Yeah.
and that's also been a hurdle.
Yeah.
So my patients, who are having drop attacks unresponsive to gentamicin, they need a labyrinthectomy, and they can't really wait for a couple of months for him to find a slot. So
Right.
they end up going to see somebody else in the group, and it's not helped them out as much as I wanted to.
Yeah. Yeah. How's the music teaching been?
That's great.
Yeah.
That's good fun.
Yeah.
Yeah, I mean, it's only once a week, but I do love doing it.
Right. I was impressed to hear that they were doing the routine COVID testing for a while.
Well, yeah, so they were from March of 2020 until just this till September. So for the first year and a half of the COVID crisis, they were totally Zoom. Nobody was allowed on campus at all.
Okay.
But then they went back to full on campus in the fall semester of 2021 in September. And the way they felt they could do it is students all had to have proof of vaccination, and everybody gets weekly test. You have to get a formal PCR test at the beginning of the semester, and then everybody gets a weekly rapid test once a week. And if you were exempted from vaccination for some medical reason, you have to get tested twice a week.
Wow. Okay.
And so I get tested once a week. I go over there once a week and get a quick test. And anyway,
Yeah.
so that was what happened. I had 6 weeks where I wasn't tested because I was on sort of end of the semester and over the winter holidays. When I came back, I was positive.
Yeah.
So,
How did the
but so everybody else, I mean, all of us are vaxxed and boosted, and everybody still is converting. It's such I assume it's Omicron. It's just so incredibly contagious.
Mm-hmm. Yeah, that's what we've seen. I mean, through the first, couple years of the pandemic, at least through our department, people we worked with, I don't think that anybody really caught it. And then with this latest wave, certainly there's been more people who have had it. And so, I mean, probably some combination of this is just much more infectious and it breaks through the vaccines. And then there's also probably some amount of COVID fatigue and people changing their behaviors.
Right. So you know what I just thought of? If we do questions, how am I going to hear the questioners?
Yeah, I think what we'll probably do is I'll probably repeat the questions back
Okay.
into the
All
microphone
right.
so you can hear them.
Okay, I'm just gonna. I'm still here. I just need to grab something to clean my glasses because you're all blurry.
Okay, we've got about 10 minutes here. Let me get some
Yeah.
water. How's it been getting contractors and people to do the work on the new house?
Uh, that's an interesting story.
Yeah.
We um, we were out there at the end of the summer, um, for our usual summer backpacking trip and whatever. And before we came back here, what the like our highest priority is there's a leak in the roof in one place. It's an old Spanish tile kind of roof, and so Lisa found a couple of contractors. We had roofing guys, and she had one come by to give us an estimate. And we really liked the guy. The estimate was kind of what we expected. And right before we left town, just on a whim, she contacted the city planning office, which is the place that does all permitting for
Mm-hmm.
construction work, just because we knew we were going to need permits we need plumbing and electrical and all kinds of stuff. And the planning office said, "Oh, that house, we love that house. That's this very famous block." So it turns out it was designed by a very famous architect, and it's a very particular example of his early 20th century hacienda style, and it's like an historical house, and we can't just fix it. Everything has to be done with a contractor who specializes in historic restoration, and design work has to be done with an architect who does historic restoration. So, like, you can add an extra zero to the cost of everything,
Oh my
and
gosh.
you can double or triple the timeline.
Yeah.
So it was. So we found an architect and a contractor, and we really love them. But it's the whole thing is expanded into a major
Major
undertaking, and so we're emailing back and forth, and we're having Zoom meetings because we're 3,000 miles away.
Yeah.
But we've got to get everything's got to be designed and planned and permitted and done to, we have structural engineers coming in to tell us if the roof can bear the weight of this old style of tile. It's just, anyway, it's what do I want to say? It's more involved, but not less gratifying.
Right. Yeah. Yeah. That's
And
I was gonna say, so we bought a house this past year, and with sort of everything going on with the housing, market and like labor shortages. It's funny. We were looking at getting the interior painted, and we contacted a handful of painters, and most of them were just like, "Nah, we're not interested. We've got plenty of work lined up. Good luck." And we're like, "Well, you haven't even given us a quote yet. I mean, we're offering to pay you, of course, but it seems like it's a challenging time to get stuff done."
oh, you got to find a couple of college kids.
Yeah, it's true. Although a few of my friends did that. I think they painted the exterior of houses for like a summer job in high school.
Yeah,
Yeah,
they're not professionals.
yeah, yeah. I don't think they did a great job.
Yeah. Well, owning a home is a never-ending series of learning how to do things that you're never going to do again,
Yeah,
because next time you'll hire somebody,
yeah,
and
yeah,
so
yeah.
it's I have renovated several old homes over the years, three of them, and this one in California is the fourth, each time I've done less and less of it myself. Um, this one I'm not doing any. Well, I mean,
Right.
I do little bits myself, little projects, but I mean, this is major. All the plumbing, all the electrical, all that. We're going to put in a whole new kitchen. It's going to be a big
Yeah, that
three,
doesn't.
four new bathrooms. It's going to be a big project.
Yeah,
So
that doesn't sound like good do-it-yourself stuff.
now I'll change the light bulbs.
Right.
That's so. How old is your baby?
um, like 5.5 months now. Yeah.
So almost ready for college.
What's that?
Almost ready for college.
Yeah, getting there. He's got to learn to crawl first, I think. I think that's a requirement for entrance, but no, it's been good. His name is Alexander, and he's really cute and healthy, and it's been it's been fun. Definitely a game changer for life. but it's been a good one.
Oh. So where did you find your wife?
In Boston. So she was
No kidding.
she was my girlfriend there for the last year. I think you know what, you met her at some of the graduation events, Katrina. So I convinced her to move out here to Tucson with me, and
Oh, and what did she do? Remind me.
so she went back to school for acupuncture and traditional Chinese medicine, and so
Oh, interesting.
yeah, so she was in school in Boston and was able to transfer to the school here in Tucson, and she just graduated over the holidays, and so she's taking her board exams right now. They have a series of 4 of them, and so she got the first one done with this past week, and so she'll probably have a couple months or maybe a little bit more of sort of going through those and then setting up a practice. Thanks, Chris.
Nice.
Yeah, so
Send her tinnitus patients.
definitely. Yeah, there's plenty of good referrals from ENT for that kind of stuff.
So you named your boy Alexander. What do you call him?
Um, so his nickname when my wife was still pregnant was Bopper, so he still gets called Bopper a lot. But he'll probably go by Alex. We'll see. We'll see how much.
When our youngest, when he was little, we had all kinds of names before he was born, but once he was out, he got nicknamed Bug because the way he scrabbled along the floor forward and backward and get trapped under the couch all the time, and and we still call him that. He's 26.
Yeah.
So
that's what I wonder how long Bopper is going to stick. I mean, as long as he's kind of moving around erratically and bopping into things, we'll probably keep calling him that. All right, great.
yeah, before Jay was born, for a while we were calling him Java because he kept Lisa up all night, kicking and squirming in utero.
Yeah.
And we had good friends who were Italian, and in their pregnancy they called their kid La Cosa, the thing.
The thing, yeah.
That's fun.
Yeah, it's been very good.
So I'm thinking 5.5 months. So he must be able to sit, just about sit unassisted. When you prop him up and he'll sit there.
Yeah, he needs a little bit of support for that, but just recently his head control got a lot better, so we can put him in a high chair now, and he does fun.
He rolls over by himself both ways.
Yeah, and we're starting to give him some real foods, which is fun. So.
And he's been social smiling for a while.
Oh yeah. He's a pretty smiley guy. So.
Yeah, they learn that early. Otherwise, nobody will change their diaper. It's like if they can't win you over with a smile, it's.
Yeah, that's a survival mechanism.
That's right. Yeah, from birth to age 2, the kids are learning how to push your buttons.
Yeah, they learn that. They learn that quickly. He's already pretty good at that, I think.
That's good.
Yeah. All right, good. Well, we've got 8 o'clock here. We've got a pretty good audience in here.
Okay.
I don't know. I'll make an announcement first for anybody who might be getting breakfast or in the registration area. Chris, is my microphone projecting well? Can you all hear? All right, wonderful. Good morning. So we'll get started. Thank you all for joining us on this last morning here in ENT in the Desert. This is the otology session. My name is Nick Dewey. I'm an assistant professor here at Banner University Medical Center Tucson and University of Arizona, and also director of the otology, neuropathy, and skull-based division. It's my pleasure to introduce Dr. Stephen Rausch, who is joining us via Zoom. He's a professor of otolaryngology at Harvard Medical School and director of the Vestibular and Balance Testing Center at Massachusetts Eye and Ear, and also division head of the vestibular division of otolaryngology at Mass Eye and Ear. He was going to join us in person, but unfortunately the winter weather that's been ravaging the middle of the country prevented his flights from happening, and so nonetheless we're very happy to welcome him via Zoom. He was one of my mentors in fellowship, and I would say that almost everything that I use in my practice of dizzy patients, I think I've
I've adapted from what I learned from Dr. Roush, and so it's very nice to see you again via Zoom. He has 2 talks today. He's going to give them one after another. We'll take a pause in between for some questions. He's also offered to give his email afterwards, and so if you guys write it down, or if you need if you need it later, feel free to contact me or anybody from the conference, and we can get that to you. And he's offered to take questions and have further discussions offline. The 2 talks that he's giving today, the first one is the practical management of the dizzy patient, and the second one is migraine and Meniere's, one disease or two. So with that, Dr. Roush, welcome, and take it away.
Thanks, Nick, and good morning, everybody. I do want to thank Nick and the organizers for inviting me to be here today, and I do want to tell you all how very sorry I am not to be there in person. This is not what I planned, but we'll make the best of it. I'm going to bring up my slides now. Okay, can you see that, Nick?
Yes, that's looking good.
All right, great. So here is my official first slide. Here is my branded first slide, so you can see my Harvard and Mass Pioneer affiliation, which the department likes us to do. I have no disclosures. The talk I want to give you today is about assessing a dizzy patient, and I really want to emphasize 2 things. The first is that I am not talking about emergency room assessment of the dizzy patient. The way we assess somebody in an emergency room who has an acute vestibular crisis is the go, no-go decision about stroke. That is not the focus of this morning's talk. What I want to talk about is when you see dizzy patients in your office. The second thing that I want to emphasize is that this is all about being direct and efficient. It's about the assessment that gets you 2/3 or 3/4 of the way to where you need to be in taking care of these patients. I am not going to go into detail about the treatment of every different dizzy condition. My first slide here is a cartoon about decision making, and it has really nothing specific to do with dizziness. It's a cartoon about any kind of decision making, and on the vertical axis is your ability to make a good decision, and on the horizontal axis is the amount of information you have. And as we collect information, our ability to make a good decision gets better and better up to a point. And if you collect too much information, your ability to make a decision goes down. And I'm sure you can recall as a medical student, or for those of you who are still in academics, when you have a medical student and you send them into the room with the patient, they're in there for 45 minutes, and they come out with 12 pages of single-space notes and not a clue what the problem is. And you will walk in and in about 2 minutes collect a few bits of information and know exactly what you need to know. And so the structure of this talk is to help you find this spot when you're in the room with a dizzy patient. The only anatomy or physiology that I'd like to remind you about is here on this slide. Sense of balance is different from every other sense. Each of your other senses has only a single input. You see with your eyes, you smell with your nose, and so forth. But balance gets information from all over the place. You have 5 balance organs in each ear that read head movement. You have vision that tells you where you are, and you have proprioception and other somatosensory inputs. All those inputs converge in the vestibular brainstem, where they are compared and integrated in a very precise way that you learned as a toddler when you were learning to sit and crawl and walk. After the brain does that sensory integration, it sends messages back out. Some go to your eyes as an image stabilization system, the vestibulo-ocular reflexes, or VOR, so you can drive on a bumpy road and still read the street signs. And some of those signals can go down your spine, the vestibulospinal reflexes, so you can stand and walk and dance. And if there's a problem anywhere in this system, the sensory inputs, the central processing, or the motor outputs, the patient feels like they have a balance problem. So that's all you need to be reminded of about anatomy and physiology. The approach I want to recommend to you today has two parameters. Here's the first one. What flavor of dizziness does your patient have? And everybody knows dizziness comes in 4 flavors. The first flavor is near syncope. And I expect most of you have had this. If you're down on the floor doing crunches and you're a little dehydrated, working out at the gym, and you stand up too fast, you have a brownout. You get a little woozy, your vision may get a little dim, you feel like you might go down. Near syncope is the feeling of impending loss of consciousness, or feeling like you might have a blackout. And this is obviously a symptom of inadequate cerebral blood flow. So you might see this in someone who's dehydrated, somebody orthostatic, somebody with cardiac valvular disease, with vasovagal or dysautonomia problems, somebody with carotid or vertebrobasilar stenosis. But this is clearly a symptom of cardiovascular problem, and really does not belong in my office or yours. The second flavor of dizziness is disequilibrium. And I will define that for you as a feeling of off balance. And I'm going to break it down into 2 subtypes. One kind of, and this is based, of course, on what the patient tells us when we go in and ask them what the problem is. And they say, well, I'm dizzy. And you say, no, I don't know what dizzy means. What do you mean when you say dizzy? What do you really feel? And if they start to tell you that they feel off balance, or like they might fall, that's disequilibrium. And we see 2 subtypes. One of these is the patient who says, well, I feel off balance. And I say, well, how do you feel sitting in the chair here? And they say, oh, fine. I said, what about when you're lying in bed? No problem. What about when you lie down into the bed or sit up or roll over? Nope, no problem. You drive? Sure, no problem. Well, when do you feel dizzy? And they feel dizzy as soon as they stand up, or once they're up on their feet. So the subtype of disequilibrium that exclusively occurs when someone is standing is gait disequilibrium. And that makes me think of long tracts. They're not sending information up the spine, or they're not sending information down the spine, or there's something in the middle like a cerebellar ataxia or a movement disorder that's making them unsteady on their feet. Now, I'll examine those patients, but I'm really thinking you need a neurologist. You know, they have peripheral neuropathy, they have spinal stenosis, they have polymyalgia rheumatica. There's something going on that's really not in my wheelhouse. The other flavor of disequilibrium, or subtype of disequilibrium, I would call global disequilibrium. And these are people who feel off balance or lost in space all the time, or lots of the time. Anytime they move their head, when they bend over, when they stand up, they've given up driving, or they'll only drive a very limited way because the head movements set them off. And those people certainly belong in my office. Does not mean it's ear disease, but they certainly deserve my attention. The third flavor of dizziness is vertigo. And the formal definition of vertigo is an illusion of motion. If the patient feels that they are moving or the world is moving about them, they have vertigo. And the difference between self-motion and world motion is totally irrelevant. Obviously, if they're spinning, that warms the cockles of my heart because, you know, whirling vertigo is something we all know and love, but it doesn't have to be spinning. It could be tumbling, cartwheeling, bouncing up and down like being on a pogo stick, swaying on the deck of a ship, feeling the floor suddenly drop, like that feeling when an elevator drops a few inches. All of these kinds of illusory motion are versions of vertigo. They certainly belong in my office and yours. And finally, the flavor I've listed here as psychogenic. And psychogenic is a dizziness that's purely psychological. And when you press the patient to give you a description of what do they mean when they say dizzy, what they tell you is they feel spacey or out of it or disconnected. Some people say that it's like they're watching the world on TV, but they're not really there. If you've ever taken too much NyQuil, you know the feeling. It's just being a little out of it. And this is a common symptom in patients who are having anxiety problems. So the near syncope patients go to the cardiologist or the internist. The disequilibrium patients are mine, but if it's only gait related, I'm going to end up sending them to the neurologist or physiatrist for further assessment. If they have vertigo, they're certainly mine. If it's psychogenic, I evaluate them because being anxious or neurotic does not protect you from inner ear disease, but I am also planning on a psych referral. The second parameter of this approach is the trajectory of disease. And by trajectory, I mean the course of symptoms over time. Now, here are three cartoons for you. The vertical axis is symptoms. I've not given you any units, but I'll tell you that the top is normal and the bottom is rotten. And time is flowing from left to right, and I have not given you any units of time, seconds, minutes, hours, days, weeks, months. The first cartoon is an illness where the patient suddenly got precipitously worse and they make an asymptotic approach back toward normal. And I'm not there in the room to ask you, but if I asked for a show of hands, how many of you know what balance disorder that might be? Most hands would go up, and you are probably thinking of vestibular neuritis or labyrinthitis. The middle cartoon is somebody who has relapsing symptoms. They get precipitously worse, they recover, but over time their recovery isn't really bringing them back to completely to normal. So their baseline is deteriorating, and that's punctuated by episodes of more severe impairment. And that might be the cartoon you would draw for Meniere's disease. And finally, we have a cartoon of a patient who's having frequent brief spells of vertigo, and then it goes away and they're fine. And obviously that's BPPV. Now, I want to stress to you and emphasize just how powerful this concept of trajectory is. With no units of time or severity, just the sketch. You can sketch it in their office record. You can sketch it on a piece of paper, visualize it yourself, ask them to draw it. If you just have the shape of symptoms over time, you have a powerful tool to assess your patient's symptoms. And of course, there's also a trajectory of response to treatment. That's a separate discussion. So taking just these two parameters, flavor of dizziness and trajectory, now I want to show you how we might apply this. And I'm going to start with patients who have vertigo. These are the patients who have true vertigo, and I have sneaked in one other parameter here without units of measure, and that's hearing. So here's a matrix for patients who have acute vertigo. And in the vertigo side of this, I've broken it up into patients who have their vertigo in recurring attacks and their patients who have vertigo that came on and it's just there, it's lingering. And then I've added hearing loss, yes or no. I've not asked if it's fluctuating, I've not asked if it's unilateral or bilateral, I've not asked if it's old or new, just yes or no. And this matrix is based on a study that I did with one of my fellows years ago where we basically made this a questionnaire. Do you have vertigo? Is it persistent or attacks? Do you have hearing loss, yes or no? And we had the patient fill that out, and then I would do my full workup when we looked at the final diagnosis versus the patient's answers. And it turns out that there's a relatively unique response to filling in this matrix, and I'm sure you can do it. Here it is. without any other information about duration of symptoms, frequency of symptoms, aspects of the hearing loss. If you have a patient who has episodic vertigo and hearing loss, they probably have Meniere's disease, more than 60% of them. If you have a patient who has episodic vertigo but no hearing trouble, they probably have BPPV. Now, if the vertigo is hours in duration, yeah, it's certainly Meniere's. If it's, less than a minute in duration, yeah, it's BPPV. But you actually don't even need to know that. It is such a sharp knife cleaving these groups that this simple matrix will get you the right answer 60 to 80% of the time. And in the right-hand column, if somebody has persistent vertigo and it comes with hearing loss, it's labyrinthitis. If they have the same illness with no hearing loss, it's vestibular neuritis. So you can take your acute vertigo patients and very rapidly dump them into these bins, and you are probably going to be right 60 to 80% of the time without even knowing any of the details. Your office nurse, your secretary, could probably put them in the right categories. And then for you to get a hearing test and whatever other workup you choose. Unfortunately, not everybody fits in this matrix because not everybody has acute vertigo. So for the last few minutes, I just want to show you the 4 other conditions that account for almost every dizzy patient that comes into my office. And here they are. These conditions do not fit the matrix because they either have disequilibrium or a mix of disequilibrium and vertigo. The first is progressive disequilibrium of aging. And these are the patients who come with this scenario. It's usually an aged patient brought by their adult children. They report that their balance is deteriorating. They have trouble getting out of the chair. They have trouble going up the stairs. They've fallen a couple of times. Often what brings them to see you is that they told their primary care doc they were dizzy, and he put them on meclizine, and they got drastically worse. Or they had a hip replacement, so now they don't get any hip proprioception. Or they had one cataract fixed, so one eye is in focus and one eye is out of focus. Some kind of medical intervention that made their trajectory suddenly drastically worse. And of course, these patients have multi-system decline, and they need hearing aids, they need vision tune-up, they need podiatry to take care of their bunions and their footwear. They need their medication list debrided so they're not on sedating meds. They need physical therapy. They need their home made safe for seniors with non-slip surfaces and night lights and safety grab bars and so forth. And you can do a ton to help these patients. But probably the biggest thing you can do is take them off meclizine, which is a disastrous drug. Here's the second condition we see, migraine. We're going to talk more about migraine in the second half of my session with you this morning. But of course, the migraine you and I learned about in medical school is a profound throbbing headache, ice pick through the eyeball kind of headache with nausea and vomiting and light sensitivity. But that's only a description of a migraine headache, not of migraine, which is a broad neurological disturbance that affects many things. So we're not talking about your bubby's migraine. We're talking about light and sound sensitivity, screaming unbearable tinnitus and ear pain and ear fullness, tremendous intolerance of self-motion and visual motion, of motion of the world around you, intolerance of visual flow and flicker, intolerance of other kinds of visual chaos. And obviously, this is everyday life, although during COVID, we get less of it. Abnormal pain processing. Any sensory stimulus can be intensified or distorted. And it turns out that 25 to 30% of people with history of migraine headache or ocular migraine have balance symptoms. And we call that vestibular migraine. So the modern notion of migraine is that it's not just a headache. Migraine is a global disturbance of sensory signal processing. If you don't take anything else away, take that. So migraine is a super common cause of dizziness, way more common than most of the other things we see. It's treatable, and it's actually very interesting from neurobiology point of view. And migraine was not a part of ENT practice when I was training, perhaps not when you were training, but it sure is now. People with migraine have personal history of migraine, family history of migraine. A lot of them will tell you, you ask, do you have any other health problems? And they say, nope. And I say, what about migraine? And they say, oh, not anymore. Wrong. If you've ever had migraine, you're a migraineur. You may have had it as a child. You may have other migraine indicators, symptoms that are triggered by diet, by stress, by pain, by allergy, and so forth. Those kind of environmental or health triggers are a big red flag for migraine. And a lot of migraine patients carry a diagnosis of so-called atypical Meniere's. They have vertigo but no hearing loss. And I'm sure you now all know that a lot of people who think they have recurring sinus disease actually have mid-facial migraine. Their CT scan is pristine, no sign of actual inflammatory sinus disease. We see patients who have migraine headaches with vertigo. We see vertigo with no headache. We see so-called floating woman syndrome, where the people feel like they're on marshmallows all day. Not necessarily temporally related to headache. We see basilar artery migraine, a posterior fossa migraine with verbal aphasia and visual inversions where the world seems to turn upside down. And we see people who are not having symptoms that you would think are migraine, but when you diagnose their BPPV or their vestibular neuritis, they're not following the recovery trajectory that you expect. Their BPPV doesn't respond to an Epley maneuver, or it keeps changing sides, or both ears are involved, or they're a young, fit, healthy person who gets vestibular neuritis and 6 months later they're still disabled. If somebody's not following the flight plan of recovery, you have to think about migraine. The third condition on my list of problems that doesn't fit the dizzy matrix is called persistent postural perceptual dizziness. Some of us call it 3PD, PPPD. These are patients who come in reporting a sort of floaty-boaty, lost in space disequilibrium. Sometimes I have a sort of rocking, swaying sensation, very intolerant of self-motion or visual flow and flicker. A lot like the migraineurs, very high comorbidity of anxiety and panic attack, but no migraine. They don't have headaches, they don't have a family history of migraine or a prior history of migraine, and their anxiety is revved up sort of along with these symptoms. This is a hypervigilance syndrome. It's an anxiety disorder, what we call a somatic anxiety disorder. And it's patients who are so worried about their balance, so focused on their balance that they lose their normal relaxed fluid movement, and they have weird twitchy muscle contractions, and they can't find their balance point. And they're treated with SSRI, SNRI medications, and gradually over 3 to 6 months the symptoms go away. And finally, we see patients with cervical vertigo. In these patients, the scenario is a history of recent or distant past whiplash, cervical disc disease, and degenerative arthropathy, repetitive stress injuries. Sometimes it's just people who carry a lot of stress in their neck. And the story is a feeling of sort of floating, not quite normal balance, and it's punctuated by brief zingers where the patient makes a head-on body movement, they turn or they look, and whoo, they just get a little spin zap where everything tilts or lurches or spins for a fraction of a second. If you are not paying attention and you do a Dix Hall pipe test where you rotate their neck and hyperextend it off the end of your table, they might get vertigo, and you could mistake this for BPPV. but it does not have the very consistent, repetitive nature of BPPV. This is very erratic and inconsistent. And if you question them, they often have muscle tension headaches, and if you start poking around, you'll find trigger points and guarding. You might even make them dizzy with your pressure if you hit a trigger point. And these people need some neck work. They either need a massage therapist or a physiatrist and some physical therapy. So let me summarize this. The first thing you need to know is what flavor of dizziness does your patient have? Near syncope, back to the internist for a workup of their blood pressure and central circulation. If they have disequilibrium, you try to figure out if it's exclusively gait related and they need a neurologist, or it's more global and they need you. True vertigo, absolutely yours. And psychogenic dizziness is sort of disconnected, spacey stuff. Listen to their symptoms, examine them, but keep a psychologist or psychiatrist on your speed dial. Think about the trajectory of symptoms over time. If your patients have true vertigo, see if they'll fit in that matrix. If it's vertigo with hearing loss, it's probably Meniere's. If it's episodic vertigo, if it's episodic vertigo with normal hearing, it's probably BPPV. If it's persistent vertigo with hearing loss, is labyrinthitis, without is neuritis. If it does not fit the matrix, think about progressive disequilibrium of aging, vestibular migraine, persistent postural perceptual dizziness, or cervical vertigo. And if after all of that, you are still scratching your head, maybe you need to find a neurologist to help you out. So I would be happy to take some questions briefly, and then we'll go on to a second talk. And because I'm not there to schmooze with you at the coffee break or at lunch, I'm also putting up my email address here. So if I don't get your questions this morning, do not hesitate. Please send me your questions. Nick?
Yes.
You got some questions there?
Let's see, any questions from the audience? Yes.
Dr. Rausch, what ideas or treatments do you have for patients with chronic Malday debarkment syndrome?
So Dr. Rausch, the question was, what do you do for patients with chronic Malday debarkment syndrome?
So Malday debarkment syndrome is one of three conditions that cause a sort of rocking boat sensation. We see it in cervical dizziness, we see it in MDD, and we see it in persistent postural perceptual dizziness, the thing I described for you just a moment ago. And you have to figure out which of those three conditions you're dealing with. The cervical dizziness gets the brief zingers, and you can elicit the neck history. Postural perceptual dizziness, 3PD and MDD have the exact same subjective description of dizziness, but the exact opposite occasions when it occurs. Patients with PPPD, they feel their rocky boat feeling when they're up on their feet, and it's aggravated when they're in motion. When they sit down in a high back chair, when they lie down, they immediately feel normal, but the symptoms come back when they're up on their feet. MDD patients, it's the exact opposite. When they're riding in a car, they feel fine as soon as the car stops. If they're standing still, sitting in a chair, lying down, that's when they feel the motion. So first you have to make the right diagnosis. MDD is super difficult to treat. It's easy to prevent. If you have someone prone to it, you pre-medicate for travel with a vestibular suppressant. You can use meclizine starting 24 hours before the trip, or a short-acting benzo an hour before the trip. But once they've got it, it's really hard to treat. You can wait it out. You can try to send them for some physical therapy, and if you have a patient therapist who takes it very slow, they might get over it. But it's a very challenging condition, and I don't have a fabulous treatment for it.
Any other questions? Well, Dr. Roush, that looks like all the questions for the moment.
Okay, let me move on to the second talk. I need to just drop out of this slide deck into another one. Give me a second here. We're getting there. Okay, let me share the, whoops, wait a minute, I clicked the wrong button there, hang on. It's opening, here we go. Okay. We want this and this. Are we getting the right thing? Not yet. Sorry, I'm having a technical thing getting my, oh, there we go. Can you see that now?
No, not yet.
Okay, hang on. One more try.
There we go.
And there we go. You got the slide now?
Yes, looks good.
Okay. So what I want to talk about in this next session is Meniere's disease versus vestibular migraine. And as I said earlier, migraine was really not ENT when I was training, but nowadays migraine has become a gigantic part of ENT practice. And whether you're a rhinologist and need to deal with it as a sinus thing or an otologist and need to deal with it as a dizzy thing, it's gotten to be really big. And it turns out that there's a diagnostic dilemma between these two conditions here, Meniere's disease and vestibular migraine, and the more we look at them, the harder it is to separate them. So I want to discuss that and bring it to a point of some practical use to you. So you all know the diagnostic criteria for Meniere's disease. This is a picture of Dr. Meniere back in the 1860s when he described this. Meniere's disease is a sign when the ear is degenerating and it causes episodic vertigo of 20 minutes to 12 hours duration. And when there is audiometric documentation of fluctuating or progressive hearing loss, and when there's tinnitus or aural fullness in the affected ear. Here's a cartoon of a trajectory of illness as I just described to you, with normal on the left and a dead ear on the bottom. And what you see in this picture of symptoms versus time is that the ear is degenerating, and after it's degenerated for a while, the function begins to fluctuate. It's a lot like having an old car. When you bought it, it ran great, but as it deteriorates, it becomes unreliable. And if it keeps degenerating, eventually that car doesn't run at all. Meniere's disease is this time window when the degenerating ear becomes unreliable. It was degenerating before it earned the label, and it keeps degenerating, and that tail end of the ear lifespan is called burned out Meniere's. The ear doesn't have the horsepower to make vertigo anymore, and the hearing is useless. And so, if you really want to just summarize Meniere's disease, it's a fragile ear. We've known since the 1930s that it's associated with endolymphatic hydrops, and we've also known that any damage to the ear can lead to homeostatic failure, which produces this spectrum of symptoms and findings. And you know what? I could add to that list on the left: bad karma, sunspots, alien ray beams. It doesn't matter. If the ear is damaged, it could be dizzy or deaf or both. If it's both and the symptoms are intermittent, it's Meniere's. Migraine also has diagnostic criteria, and these are migraine headache diagnostic criteria as defined by the International Headache Society. Multiple attacks lasting 4 to 72 hours, and some of the attacks having a unilateral quality, a pulsating quality, an intensity that is so severe that the patient is disabled during the attack, and the attack is intensified by routine physical activity, and they have to occasionally at least have nausea or vomiting or other sensory disturbance. So if you look at that, you know, it's very similar to a Meniere's story. It's just a slightly different spectrum of symptoms. And after years of negotiating, the International Headache Society formed a committee with the Barony Society, which is a society of dizzy doctors, and they came up with consensus diagnostic criteria for vestibular Meniere's. Vestibular Meniere's is moderate to severe vestibular attacks, vertigo and disequilibrium, of 5 minutes to 72 hours, history of migraine headache by IHS criteria that I just showed you, and at least one migraine feature with at least half of the vestibular attacks. Could be vertigo that transitions to headache, headache that transitions to vertigo, vertigo with light sensitivity or sound sensitivity or visual aura. So overlap, temporal overlap of the symptoms. So if you wanted to look at what's going on in migraine, there is a genetic or acquired sensitivity in the brain. We see it after concussion. We see it running in families. We see that it's much more common, 3 to 5 times more common in women than men. And it's a genetic or physiologic susceptibility to this problem. It is activated when environmental or internal triggers exceed the threshold of this phenomenon in the neurotransmitter chemistry. It stimulates a phenomenon called cortical spreading depression of abnormal electrical activity, and that electrical activity occurs with activation of the trigeminal nucleus, and all the areas of the head and neck and thorax that are innervated with trigeminal branches could be affected with a phenomenon called neurogenic inflammation, which is a change of capillary permeability and inflammatory infiltrates and nociceptive, a painful feedback pathway into the trigeminal brainstem. So this is the simple encapsulation of migraine. It's a sensitive brain. So the first thing I'm going to tell you is that if you're listening to your patient's dizzy story, and as you hear the story, it sounds like it's really an ear-ish story, you're probably going to be thinking about Meniere's. If you're thinking it's kind of a brain-ish story, you know, all kinds of stuff going on, it doesn't sound like an ear. Headaches, light sensitivity, aches and pains, numbness and tingling, panic attacks. There's all kinds of other weird stuff going on. You should be thinking about migraine. I showed you this cartoon in my first talk, reminding you that balance depends upon taking multiple sensory inputs and integrating them in the brain. But now I've also told you that migraine screws up the calibration of sensory signals. Any sensory signal in the body can be intensified or distorted. Light, sound, smell, touch, taste, any of them. So if the signals are not calibrated properly, when they get to the vestibular brainstem, they don't fit together anymore. And so we believe that 75 or 80% of vestibular migraine is a failure of sensory integration in the brain. And it causes all of this floaty, boaty, dizziness, and vertigo, and nausea, and trouble with vestibulo-ocular gaze tracking, and gait stability problems. That accounts for 75 or 80% of vestibular migraine patients, but there's another 20 or 25% where the problem really is in the ear. This is just some figures taken from a paper written 15 years ago, 16 years ago by Zoltan Vass and colleagues in Portland, Oregon, where they took guinea pigs and they stimulated the trigeminal nucleus in the brain, and they measured changes in cochlear blood flow. And when they looked under the microscope, this trigeminal nerve stimulation caused neurogenic inflammation, capillary leakage, and inflammatory infiltrates, exactly what we see in a migraine attack. And so this has proven, at least in the animal model, that if you have these kind of trigeminally mediated neural disturbances of migraine, you get changes of blood flow to the inner ear. And it's very plausible that that change in blood flow could cause fluctuating hearing and attacks of vertigo. Now that may sound like another disease you know of, Meniere's disease. And so we believe that there are patients who have a Meniere attack caused by this migraine pathophysiology. And you know, the ear is a very delicate place. Its circulation is very tenuous. It's end arteriolar circulation. There's only one blood vessel that feeds the ear. And if this is a patient having relapsing episodes where that blood supply is in jeopardy and it keeps getting choked, eventually you begin to develop some end organ damage, and the ear begins to degenerate. And if you have a degenerating inner ear with progressive hearing loss and attacks, well, that is absolutely Meniere's disease. And even if you took migraine off the table, that Meniere snowball keeps rolling down the hill. Here's a comparison of the vestibular migraine criteria on the left and the Meniere criteria on the right. First row is the severity and duration of attacks. The second row is headaches versus hearing loss. The third row is other symptoms. And I want to highlight that first row. If we look at the migraine criteria, at least 5 attacks, and they're 5 minutes to 72 hours, and you look at Meniere, at least 2 attacks, 20 minutes to 12 hours. Well, 20 minutes to 12 hours fits inside 5 minutes to 72. If you met Meniere criteria, you automatically meet migraine criteria. However, the next couple of rows don't exactly line up. Meniere's disease has hearing loss. Migraine patients don't necessarily have a hearing loss. And on the other hand, migraine patients have all kinds of other neurological symptoms, and you don't really expect that in Meniere's disease. Meniere's disease is ear-ish, migraine is brain-ish. And if we drill down on that, if we look at the vertigo, the first row, migraine, the vertigo could be second to week. Meniere's, it's minutes to hours. That doesn't really help us divide them. You could have migraine where the attacks are too long to be Meniere's disease, but you have some where they absolutely overlap. Sensory neural hearing loss in the second row, well, Meniere's has to have it. It's one of the absolute diagnostic criteria. But 20% of people with vestibular migraine get sensory neural hearing loss. So that does not differentiate these two groups. What about other vestibular symptoms? Well, by definition, VM has other vestibular symptoms. Meniere's, about 15 or 20% of Meniere patients have adjunctive balance symptoms besides their definitive vertigo attacks. So that does not absolutely differentiate the groups. Neurosymptoms are probable in VM and they're not present in Meniere's. Meniere's does not cause headache or light sensitivity or belly pain. VM should have headaches. They may not be temporally related to the vertigo, but they should have some headaches. Otherwise, we wouldn't have ever diagnosed migraine in the past. Meniere's, it's not a headache disease. Well, The other red flag things we worry about are called migraine indicators. And this is a laundry list of patient symptoms that should raise your antennae about possible migraine. Other history or concurrent headache, but also facial pain, ear pain, and I would lump into there chronic mid-facial pain and pressure that's been diagnosed as chronic sinusitis, and you find a normal CT. Photophobia, sound sensitivity, phonophobia, osmophobia is smell problems. Patients who get sick if they go down the cosmetics aisle in the department store or the laundry detergent aisle in the grocery store, who get sick from cigarette smoke and paint fumes or perfume and deodorant when they step in a crowded elevator. Allodynia is skin pain, skin sensitivity. Migraineurs often can't take a shower on a migraine day or brush their hair because their skin hurts. They can't even wear tight clothing on a migraine day. Chronic motion sickness, lifelong motion sickness is typical in migraine. And I would go so far as to say if you have an adult who has adult onset motion sickness, a woman who used to go out sailing with her husband and now she can't even stand on the dock and look at the boat without getting nauseous, that is absolutely diagnostic of migraine. Nothing causes adult motion sickness except vestibular migraine or post-concussion syndrome. Intolerance of visual flow and flicker, people who get dizzy or nauseous watching scrolling computer screens, going into shopping malls or down grocery aisle. Irritable bowel syndrome is a gut migraine and a pediatric migraine. Fibromyalgia is a muscle migraine, and a lot of fibromyalgia patients put on migraine treatment resolve their fibromyalgia. And finally, treatment-resistant or bizarre BPPV. BPPV is a very simple mechanical problem, and a single Epley maneuver or a couple of Epley maneuvers should cure it. If you or a competent PT are doing particle repositioning and 2 days later the attacks are back, and 3 days later they're back, and next week it's the other ear, and then it's both ears, then it's the other ear again, if they're not behaving like a simple mechanical problem, you should think of migraine, which also causes positional vertigo symptoms in the nystagmus. And patients with migraine are super prone to anxiety and panic attacks. If you find that your patient having these vertigo attacks that you're thinking might be Meniere's is also having a lot of anxiety and panic, that should tip you toward migraine. Now, what about the epidemiology? When we look at just migraine headache particularly, women have migraine 3 to 4 times more often than men, and between puberty and menopause, nearly a third of women meet diagnostic criteria for migraine headache. During that same age group, men, it's no more than 7 to 10% of men who get migraines. But if you lump those all together, in the general population, the incidence of migraine is 13%. I'm not in the room there with you, but if you want to just do an experiment, everybody in the room who has ever had a migraine headache or an ocular migraine, just stick your hand up for a minute. Hey, Nick, what's it look like?
I would say maybe about a fifth of the room, maybe up to a quarter.
All right, I rest my case. So if we look at all these people who get migraine, 13% of the general population gets migraine. If we take 100 patients who have Meniere's disease, 60% get migraine headache. And if we just look at that list of migraine indicators that I showed you, 95% of Meniere patients exhibit one or more migraine indicators. Migraine is seen in 13% of the population. About 25 or 30% of people with migraine get vertigo. So that would be 3 to 4% of the general population. The best epidemiologic studies of Meniere's disease suggest that it's only seen in 0.2% of the population. So 4% for vestibular migraine versus 0.2% for Meniere's, it means vestibular migraine is 10 to 15 times more common than Meniere's disease as a cause of episodic vertigo. If you see vertigo patients and you are not diagnosing vestibular migraine, you are wrong 9 times out of 10. Well, how do we handle this problem? There is no test that can differentiate Meniere's from migraine. Both of them cause potential for hearing loss, both of them cause vestibular symptoms. A migraine can cause end organ damage in the inner ear, so their VNG might look peripheral. Their vent, if you do vent, might look peripheral. There is no diagnostic test. Well, early on in the treatment algorithm, here's treatment going from left to right, and in the top, I've put Meniere's disease. Down on the bottom, I put migraine. And for both of these conditions, we start with some adjustments of triggers, of diet and lifestyle. We know that Meniere patients do best if they have a very regular daily schedule. They get up at the same time, they eat at the same time, they get exercise, they get to bed at the same time, day after day. People who skip meals and binge, people who pull all-nighters or work rotating shifts have much more symptoms. That's exactly true for migraine. We know that both Meniere's and migraine patients do best if their general health is good. Meniere patients have a fragile ear, migraine patients have a sensitive brain. If they have uncontrolled allergies and hay fever, hormone dysregulation, obstructive sleep apnea or other sleep disturbances, acute or chronic pain, anxiety and depression, other metabolic disturbances, those are stressors that may trigger their symptoms. Those things don't cause Meniere's disease or cause migraine, but they certainly aggravate symptoms. And so you want your patients to dial up good health. Both Meniere patients and migraine patients occasionally have dietary sensitivities. This is common in migraine and relatively uncommon in Meniere's disease. And the dietary triggers can be quite drastically different. What we care about in Meniere's disease is fluid and electrolytes, because we know that the homeostatic regulation of the inner ear is unreliable. So we ask Meniere patients to limit their caffeine to 1 hit per day. We ask them to limit alcohol to 1 hit per day. And we ask them to even out their sodium so they get about the same hit of sodium in every meal. I do not recommend low salt in any Meniere patients. In fact, I take all of them off of that recommendation because it tends to be neurotic, and they go on such extreme low sodium diets that the body is desperate for sodium. And if they eat 1 handful of chips, the delta is huge. They've doubled their day's sodium, and they become so brittle I can't control them at all. I never want anyone's daily sodium below 2,000 milligrams. 2 to 3K is the absolute lowest. And I have little old ladies in Chinatown who eat a traditional Asian diet, and if they eat frequent small meals and even out their day's sodium level, their vertigo goes away. So we want them to have consistent sodium, not low. In my estimation, it is only about 5 to 10% of Meniere patients who are really sensitive to diet, but we make the recommendation to everybody. And overall, between regular schedule and health tune-up and dietary factors, about 2/3 of Meniere patients quit having vertigo. In migraine, the diet has nothing to do with salt. It has to do with vasoactive amines, things that are in the dopamine and serotonin biosynthetic pathway and their neurotransmitters. So we care about caffeine and alcohol, we care about artificial sweeteners, and we care about any food that's been aged, cured, pickled, or fermented. No cheese, no yogurt, no vinegar, no soy sauce. We care about lots of chemical additives that are preservatives and colors and flavor enhancers, anything with MSG. So there are dietary restrictions, and many migraineurs are sensitive to diet. Well, I would estimate maybe 40 or 50% of migraineurs who follow this trigger management plan go into remission, and maybe 2/3 of Meniere patients will go into remission, but that still leaves 1/3 or 1/2 of my patients who are symptomatic. And here the treatments begin to diverge. If trigger management fails in Meniere's, we put the patient on a diuretic. Now, I can't see a show of hands, but how many of you think diuretics make you pee endolymph? Ridiculous. Diuretics help your ear process fluid and electrolytes. They don't make you drain endolymph. About 2/3 of Meniere patients who go on a diuretic will find that their vertigo goes in remission. On the migraine side, we also have medications, but diuretics don't help migraine. We treat those patients with migraine preventives, beta blockers, tricyclics, antiepileptics. There are 40 different drugs on the market for migraine prevention. Migraine abortive medication, triptans like Imitrex and Zomig and Maxalt, rarely will abort a vestibular migraine attack. You can try it if you want, doesn't work. Migraine vertigo, vestibular migraine has to be prevented. On the Meniere side, 2/3 of patients get better with diet and trigger management. Of the remainder, 2/3 get better with diuretic. That still leaves 10% of Meniere patients who are having significant vertigo attacks, and they end up with some kind of invasive treatment, intratympanic drug injection or sac surgery or even labyrinthectomy. But what if those patients are really having migraine causing their vertigo attacks? Gentamicin is fabulous for Meniere's disease, but it is a lousy treatment for migraine. Same with labyrinthectomy. You're not going to cure migraine with a labyrinthectomy. You're just going to make somebody a vestibular cripple. So if you reach this threshold between you've tried triggers, you've tried meds, and you're at the doorstep of invasive treatment, I suppose you could try IT steroid, because that's like chicken soup. Doesn't hurt, might help, not very often. I would recommend you consider this. Take a pause, take a step back, reconsider whether your patient has any migraine indicators, and consider putting them on some migraine trigger management, a migraine diet, or even some migraine preventive medications for a couple of months. If it doesn't work, you can always go back to the invasive treatment. But if it does work, you will have hit a big home run. So, to conclude this, Meniere patients have a fragile ear. Migraine patients have a sensitive brain. That vestibular migraine, 75 or 80% of those are central from failed sensory integration, but the remainder are peripheral because of impaired blood flow to the ear, and they look just like Meniere's. VM is 10 to 15 times more common than Meniere's disease, so you have to know how to recognize it and treat it. 20% of those VM patients lose hearing, and in these patients, they are indistinguishable from migraine. So we now know migraine is one of the causes of Meniere's disease. So I started out this talk with the question, Meniere's disease versus vestibular migraine, is this one disease or two? And here's the answer. Yes. Thanks very much. My email address is here. If we have time for a couple of questions, Nick, I'm happy to take them.
Yeah, we sure do. Thank you, Dr. Rausch. Those talks were fantastic. Any questions from the audience? Yes.
Could I have Dr. Rausch just comment on the difficult diagnosis of recurrent vestibular neuritis as potentially a misdiagnosis of migraine, I suppose?
Yes, so Dr. Rausch, the question was, Could you comment on patients who seem to have recurrent vestibular neuritis and whether that may be migraine?
Sure. So the classic sort of textbook description of vestibular migraine is precipitous onset of profound unilateral peripheral vestibular dysfunction. And if you ask those patients acutely to look in the rear view mirror, they've often had a few days of weirdness, of a little bit of on and off dizziness or wooziness before the disease really hits them. They have an acute phase of 24 to 72 hours of violent, incapacitating vertigo, nausea, and vomiting. And within 72 hours, the acute spontaneous vertigo has been replaced by profound imbalance. The vomiting has stopped, and the patients enter the subacute phase, which is 10 to 14 days when they are able to bathe and dress and keep their food down, but they are definitely still furniture walking and wall walking and being very careful. And by 2 weeks, they're beginning to move around a little more comfortably, and they enter the chronic phase of the illness. The damage to the vestibular nerve in neuritis is permanent and irreversible. It's been present on vestibular function for the rest of their lives. But the symptoms go away as their brain recalibrates, and it recapitulates that learning of how to integrate vision, proprioception, and inner ear signals. And that's called central vestibular compensation or vestibular adaptation. It typically takes anywhere from 2 weeks to 2 years, and any symptoms the patient has after 2 years are probably never going to go away. They're permanent. The majority, and so I would liken that vestibular compensation process to learning a second language. You learn to balance as a toddler, and you learn your first language as a toddler. Later in life, if you're 40 years old or 60 years old, and you get vestibular neuritis, it's like moving to a new country. You know, in a day or two, you can ask, where's the bathroom? Or can I have coffee and a pastry? But if somebody wants to talk to you about plumbing repairs or economic policies, it's months before you are fluent. And that fluency was only gained with really hard work, effort, concentration, and pushing and pushing. And when you're on your game, you will do better. And when you're sick or tired or stressed, you just don't think in that new language. That's exactly what our dizzy patients experience. For 85 to 90% of VN patients, it's a one-time illness. It's a bolt of lightning, and they never get a relapse. For 10 or 15%, there is a relapsing variant, possibly because it's a neurotropic virus that just lives in Scarpus ganglion. And we expect they might get a second or fourth relapse in a lifetime. It's not something that relapses several times a year. So the frequency of relapses should be your big tip-off, and the duration of the symptoms. If it's relapsing, you know, every year or a few times a year and it's gone in a week, that's migraine, not neuritis.
So Dr. Rausch, I have a question for you. When you were talking about the time frame for vestibular migraine attacks, you had on one of the slides that can go up to weeks. I occasionally see patients who have this sort of migraine picture, but it's an even longer duration than that. It can get sort of into the range of months. Can you talk about, do you think that migraine sometimes does that, or is this something else that's masquerading like that?
A good question. So in migraine headache, the International Headache Society makes a distinction between episodic migraine and chronic migraine. And chronic, and again, they're talking about headache, but chronic migraine is more than 15 headache days per month. And so, you know, a migraine headache actually has a prodrome that builds often for days, and then they get the full-blown attack, and then there's a postdrome where the symptoms gradually fade. And that can be days. So you can imagine if you're having those 15, 18, 20 times a month, that you're never really getting to normal in between the episodes. They're piggybacked so close together. And I think we see the same thing in vestibular migraine. When I was training 40 years ago, This was a condition called floating woman syndrome. And I would walk into the examining room and there would be a young or middle-aged woman, look great, all put together, and I'd say, "How do you do? I'm Steve Roush," and they would burst into tears. And they felt nauseous all the time. They had brain fog and cognitive dysfunction. Their husband or boyfriend was on their case because they were no fun anymore. Their kids were on their case because they couldn't drive the carpool. Their boss was on their case because their productivity at work was terrible. They had $1 million of testing and everything looked normal. And it was written off as a neurotic chick problem. And nowadays, we have totally recalibrated, and this is vestibular migraine. And if we put these patients on migraine trigger management for a couple of months, half of them come back and the brain fog is gone, their feet are back on the ground, their nausea and their photosensitivity have cleared. And if they even feel a little bit of improvement, it encourages us we're on the right track, and they end up with migraine dietary supplements or with phototherapy with a thing called an Allay lamp. You can go online and read about that, the allaylamp.com. Or they end up on migraine preventive meds. But almost always, probably 80 to 90% of the time, we can resolve this kind of chronic vestibular migraine with some combination of trigger management and prophylactic medications.
Wonderful. Yes, we'll do one more question.
Role for oral steroids or beta-histamine in Meniere's disease?
The question is there a role for oral steroids or beta-histine in Meniere's disease?
So, beta-histine is not approved by the FDA here in the United States. They have not approved it because there are no clinical trials showing efficacy. Years ago, beta-histine was proposed because it was a histamine analog, and then there was information that suggested that maybe wasn't the mechanism, and it was reproposed because it causes capillary dilatation, improved cochlear blood flow in animal models. Nobody's ever shown that Meniere's is due to lack of capillary blood flow, but anyway, the clinical trials have not ever been shown. In Europe and in South America, in Asia, when I talk to colleagues around the world who specialize in this stuff, I ask them, "Do you use beta-histine?" And they all say, "Yes." And I ask, "Does it work?" And they all say, "I don't know." In Brazil and in at least in Germany, let me just say, the normal dosing of beta-histine is anywhere from 16 to 48 milligrams per day. There are a couple of docs in Europe and in Brazil who say, no, beta-histine doesn't really work unless you give 400 to 800 milligrams a day. And one guy says you need 1,000 milligrams a day. Now, if you think about it for a minute, there is no drug that has a 100x dosing range. If it works at 4 or 8 or 16 milligrams, 1,000 milligrams would kill you. And if you need 1,000 milligrams, 8 milligrams is not going to do anything. It just doesn't make any sense. So I do not prescribe it. What was the other one you asked me about? Beta-histine and what?
Oral
steroids.
Yes.
So I do not use steroids in Meniere's disease. I will offer intratympanic steroid in patients who have failed diet and diuretic and are not ready to play in the deep end and will not go for IT gentamicin yet. I didn't say it, I think, today, but I will tell you now, all of the treatments for Meniere's disease, the trigger management, the diuretics, and the invasive treatments are to control the vertigo. There is no Meniere treatment that will preserve hearing. 100% of Meniere patients go deaf if they don't die of something else first. So if you think you're treating the hearing loss or the tinnitus or the ear fullness, I believe you are deluding yourself. I don't think those things work. So if somebody has Meniere's in their only hearing ear, their first ear has croaked from Meniere's on the first side, or they had a labyrinthectomy and now the second ear is dropping. If they have a sudden big drop in hearing and they're panicking and want a short course of steroids, I would offer it, but I would also hang a lot of crepe. I don't expect it to help. Likewise, if they're getting Meniere attacks in their only ear, this first ear is burned out or labyrinthectomized, I would offer them IT gentamicin if the diet and diuretic fail, but I don't expect it to work. If steroids do work with injection, it's like steroids in your shoulder or your knee. It'll buy you a few months, but on average, it needs to be done twice a year. I just don't think steroids, I don't find a big wow in my patients treated with steroids. Now, I also have to tell you, I have a tertiary referral practice. Right now, I see 300 to 500 Meniere patients a year, and all of them have been treated by somebody else first. So, maybe I'm only seeing the ones who have failed steroids, but I don't love it.
All right, we'll leave it there. If you have additional questions, please feel free to reach out to Dr. Rausch. His email address is up on the screen. And Dr. Rausch, thank you very much. Those were fantastic, and it's nice seeing you.
Thanks for having me. It's a pleasure. Everybody, I'm really sorry I'm not there in person. Do not hesitate to send me questions if you have them. Enjoy the rest of your conference.
Thank you. Signing off. You're applauded. All right. Next up, we have Dr. Heather Kaufman, who is an otologist and assistant professor here at Banner University Medical Center, Tucson, and the University of Arizona. She's my partner, and she's going to be talking to you about an exciting topic that has had a lot of advancement in the last few years, bone conduction hearing implants. So, Dr. Kaufman, come on up.
Good?
Yep.
And then how do I make it go forward? Just like this? Like that? Like that? Okay. Okay, and then how do I make the laser pointer work?
See the little green?
Oh, okay. Okay, perfect. Hi, does this sound okay? Good, good. I'm Heather Kaufman, as Nick pointed out, and I'm going to talk about bone conduction implants today. Just a little overview. We're going to talk about the indications for bone conduction implants and then go over the types of bone conduction implants. So the audiologic indications for bone conduction implants, the implants can be used for conductive hearing loss, mixed hearing loss, and single-sided deafness. And it's important, and I'm going to harp on this today, that patients can always have a maximum conductive hearing loss with any type of implant that we put in. These are some examples. Oh, I have to stay close here. We can have conductive hearing loss, so up to a maximum conductive hearing loss. Patients can have a mixed hearing loss, so there'll be different amounts of sensory neural hearing loss that can be had with a maximum conductive hearing loss. And then with the single-sided deafness, so in this example, the patient could have deafness on the right side and then hearing on the left side. So we'd implant the right, and then the sound would be transmitted to the left ear, and so the patients would be hearing it on the left side. Other information, patients can have a bone threshold, so sensory neural hearing loss up to 65 decibels, and with 65 decibels, there'll be only certain implants that could be placed. And then patients with an air bone gap of greater than 30 decibels may have better performance outcomes with bone conduction implants. So if your patients are struggling with their hearing aids, you may want to consider a bone conduction implant. Not all insurances cover bone conduction implants, so you'll have to consider that, but they may want to be evaluated for bone conduction implants. And so now we'll go through some of the types of implants and the specifics for each of these. Percutaneous bone conduction together in one piece, but they do separate. And then this abutment will stick out of the skin, and then the external receiver processor, this can come on and off, and this has a microphone which will receive the sound, it processes it, and this will vibrate, and this will transmit the sound through. Examples of this would be the Oticon Ponto and the Cochlear Baha Connect. The requirements for this, the maximum conductive hearing loss, and then the Ponto 4 and the Baha 6 can have sensory neural hearing losses of 45 and 55 decibels, but then this can have the maximum sensory neural hearing loss up to 65 decibels for the superpowers, for both the Baha superpower and the Ponto superpowers. And these are some audiologic examples of this. The advantages of the percutaneous bone conduction implants are they're very small. So this is how small the whole implant is. And because the incision is so small, patients can have this under local anesthesia. This is good for some of our sicker patients. And in general, this is our best hearing outcomes. And we'll talk a little bit more about this later, but these are the only implants that can have up to 65 decibels of sensory neural hearing loss. And then because the implant is so small, for patients that need to have repeat MRI scans or for any head MRI scans, this is going to have the smallest artifact, so it's best for MRI scans. This is an example of the Ponto MIPS surgery. So this stands for minimally invasive Ponto surgery. The only incision is this 5-millimeter punch. Then the cannula is placed to hold the tissue back. The drill is placed through the cannula, and then the implant is installed. And this is going to be both the screw and the abutment. And so this is the end result. So we see just the abutment through the skin here. A similar procedure is for the Cochlear Connect, but there does need to be a 2 to 3 centimeter incision. The tissue is retracted so the drilling procedure can be performed. The implant, so again, this is the screw and the abutment. The incision is placed over the abutment, and then you use the 5-millimeter punch here so that the abutment is placed through the skin, and the end result is the abutment and this small incision. The disadvantages, it does take 3 months before you can place the external receiver because you're directly placing this on the abutment. You want to make sure that the osseointegration is complete because you can kind of jiggle it when you're putting on the external receiver. It's somewhat difficult to do your own routine hygiene since you don't see it. That's difficult for the patient. And then when you're explaining this to the patient, you say, well, we're just gonna have a metal screw sticking out of your head. I think the first image that comes to mind is sort of a Frankenstein look. In all actuality, almost every hairstyle for men and women covers this abutment, but it's somewhat hard to explain that to the patient at first. The true disadvantages for this, unfortunately, is that up to 14% of patients do have some skin complications. So there can be skin overgrowth and some infections, granulations, and keloids. The vast majority of patients don't have these problems, but for those that do, this might be a one-time problem or it can be a recurrent problem. For this, we might treat this with an antibiotic ointment or a steroid ointment, and this would require cutting away the skin and hoping that it grows back better, but it can be a recurrent issue for these patients. So how this works is that the receiver processor has the sound, this converts it to a vibration which goes all the way through to the temporal bone, and it vibrates all the way down to the cochlea. So if there's any disease in the external auditory canal, we have a chronic infection, or we have absent ossicles, we just bypass this completely and directly stimulate the cochlea. So because of the problems that we have with the abutment, because patients don't really like the look of having a screw, the transcutaneous bone conduction implant was developed. It's somewhat similar because there's an internal screw that osseointegrates, and then they developed a subcutaneous magnet. The skin grows completely over this, so when the device is not placed, there is no external hardware. I don't know what I'm doing here, sorry. Then externally there's a magnet and the receiver processor. So when you want to place this, it's a little bit larger because the magnet is there, but not that much. The audiologic requirements are similar. However, it can only go to 55 decibels for the Baha Attract and 45 for the Medtronic Sophono. The advantages, so there's no external post, and so this is cosmetically appealing to our patients. And then once it's healed, the hygiene is much easier for them. And we only have to wait 1 month to activate these implants, since there's no direct connection. But unfortunately, the disadvantages were very significant. In general, because there's the magnet and it's larger, the dissection has to be more, and the patients all had to go under general anesthesia. And there is an internal magnet, so there's a large MRI artifact, so it was harder for patients if they needed multiple MRIs or they did need a brain MRI scan, that magnet did need to be removed. But the idea is that the external magnet was going to send a vibration through to the internal magnet. So this magnet had to be held on very tightly so the vibration would go all the way through the skin. And this had to be held on really tightly, and so there's pain, redness, and then significant skin necrosis. You can see this was some skin breakdown. You can see how hard this was for the patient. So this was a big problem. And then in addition, there was audiologic limitations. So the soft tissue between the processor and the implant caused signal attenuation. So just the tissue between them, there was a lot of loss of signal. And then in the high frequencies, there was loss of the signal, so there was not as much gain in those high frequencies. So the patients did not do as well, and this is where we have a lot of hearing loss for our patients. It was a similar process. So the vibrations went through the skin, transmitted down the bone, and stimulated the cochlea. So this process was somewhat similar. It's just that we vibrated through the skin right here. So now we're going to transition to an entirely different process, but I don't want to have this comic say that it's more expensive. That wasn't the point. So now a new product was being developed. So the active bone conduction implants came about. The components are a little bit different. So externally we have a sound processor, a microphone, and a magnet. And then internally we had a magnet and then an osseo-integrated implant. Examples of this are the cochlear ossia and the Med-L bone bridge. These worked differently. Both transmitted an electronic signal across the skin, and then this was converted internally to vibrations. So the Med-L bone bridge, they did the electronic signal, and then here is what's called a floating mass transducer. This is where the vibrations were. And then in addition, there are 2 titanium screws, and this also osseo-integrated, and they transmitted vibrations as well. The cochlear ossia, again, transmitted electronic signals across the skin. And then down here, they use a piezoelectric material, somewhat similar to our speakers. And then this transmitted the sound through the screw as well. The advantages, there were less skin complications than either transcutaneous or percutaneous bone conduction implants. So there was no visible abutment, so we had the cosmetic and hygienic benefits like we'd see with the percutaneous implants. and then lower strength magnets, because this had to be held on like a cochlear implant. So this magnet only had to be held in place just so it didn't fall off. It wasn't being held on really strong. In addition, there was no soft tissue attenuation. We're not vibrating through the skin anymore. We're just transmitting a signal across the skin. And then the high frequency boost, because there was an electronic signal being passed, actually the high frequency was able to be stronger. And so in the high frequencies, we're able to give a stronger signal. There still are a few disadvantages. The surgery does have to be a little bit longer and a larger incision, so these patients are under general anesthesia. The indications, the bone thresholds, so sensorineural hearing loss only up to 55 decibels. So those patients with the highest sensorineural hearing loss still need to have the percutaneous implants. And they still have a large artifact from the internal magnet, and this is an example how big that artifact can be. So if you do need to get an MRI scan of the head, that magnet would need to be removed. The Med-El bone bridge has bone thresholds up to 45 and then 55 for the osseous. And so this is an example how these are placed. The bone bridge, it has a flexible placement on the bone, so anywhere that it is able to be placed is fine. The anatomy will sort of dictate where this goes. And then the post-auricular incision can be made 5 millimeters away from the implant. So right here it can be very close. And then the skin flap needs to be about 7 millimeters or less thickness over the coil magnet so that it can be held tight and there's a nice signal across to the magnet. This is an example of the surgery here. So first there's a sizer placed, and then you'll have a tight pocket for the periosteal, a pocket placed right here. And then you drill into the temporal bone what's called a pot-shaped bone bed, so it fits really tightly right here, so the vibrations can be transmitted. And then these fixation wings are held flat up against the temporal bone, and the screws are placed right there. And then this is how the implant is put into place, the actual implant. There's a nice pocket for this. And then the transducer is placed, and then the screws will go right in here. For the osseous, the ideal location, the actuator is right in line, and then this hole in the actuator ideally would go right in line with the external auditory canal. And then these little dots are the microphone, and so ideally they'll go right above the auricle. Once you're in, you kind of look at the bone placement, and you want to sort of have it at the highest place for the bone. You can mark the actuator site, the hole in the actuator, with the methylene blue. And then you do want to make 10 to 15 millimeter distance between this actuator and the incision. This actually sits up kind of high, so you don't want to have too much tension in here. And then the skin flap needs to be about 9 millimeters thick. So for these skin flaps, if there's not 7 millimeters for the bone bridge or 9 millimeters here, if it's more than that, these do have to be thinned out. I get a little confused for all the words for these, so I'm going to make sure I try to do this as clear as possible. So for the osseous implantation, we're going to start at the bottom because this is the deepest. So the BI 300 implant is a screw. So this BI 300 screw is placed into the temporal bone. If you've done any of the cochlear implants, this is placed the same way as all of their implants. First, a guide drill is placed, then a widening drill, and then the implant is placed directly into the temporal bone. So this BI 300 is placed, and then there's internal threads, so it's going to accept this fixation screw. But before this fixation screw can be placed, this fixation screw is placed through the hole in the actuator. So it goes through the hole and out the other side. Then this fixation screw out the other side is placed with the actuator, with the implant, into the BI 300. I've tried to say this a bunch of times, and I hope this is clear. So then that's how the implant is screwed into the implanted BI 300 and held in place so that the vibrations will transmit through the temporal bone. These are my pictures, and I felt like they weren't as clear. So here is the implant, kind of showing its positioning, and that fixation screw will go right through the middle of this actuator and then be held in place. Here they're showing the implant in place and demonstrating where it is there. And then they'll close up the incision right here. This is a study demonstrating just a comparison of the cochlear ossia compared to the previous two bone conduction implants. So the cochlear ossia in comparison to the cochlear attract and cochlear connect demonstrates high frequency gain. 15 decibels improvement over the attract. 19 decibels over the attract and 15 decibels over the connect in the high frequencies, demonstrating significant improvement in the high frequencies of the ossia. And then this is just a graph demonstrating the same. The ossia compared to the Baha Connect, which is the implant that does better because it's a direct connection. In comparison to the Baha Connect, the ossia performs better at 2,000 hertz, but improvement at 4,000 and 6,000 hertz, we have 12 decibels and 17 decibel improvement in these high frequencies. So even though we have a magnet connection, because of the high frequency boost of this implant, this ossia is outperforming even the Baha Connect. So I think this is an impressive implant. And so finally, just in summary, the bone conduction implants are good for conductive hearing loss, mixed hearing loss, and single-sided deafness. And despite the fact that we have 3 options, I really think that our actual options are down to the percutaneous and active implants. Oh, okay.
Oh, thank you, Dr. Kaufman. For the sake of time, I'll Thanks, Chris. That should, there we go, there. So, hi again, Nicholas Duyer, Director of Otology, Neurotology, and Skull-Based Surgery here at Banner University Medical Center, Tucson, and the University of Arizona. My topic today is we're going to be talking about a hole in the roof, management of Tegman defects. This was on my mind a bit, not related to the ear in the past year, as we had a record monsoon season, and the rental I was in the beginning of the year, there was a leak in the roof that came down through our bedroom, and then we bought a house that had a 35-year-old roof, and so I've had to do a lot of decision-making regarding real house roofs, and this comes up a bit in my practice as well with the ear. I have no disclosures related to this talk. Many of you are familiar with what the tegmen is. It's essentially the thin plate of bone that forms the roof of the ear, or from a neurosurgeon's perspective, the floor of the calvarium. Just superior to that is the dura, which is the tough fibrous covering that contains the cerebrospinal fluid in the brain. And this illustration, which is from the Stanford Otologic Atlas, shows multiple tegmen defects, which are the bony defects. And in addition, it shows meningoencephalocele, or essentially a protrusion of brain or dural tissue into the ear. Tegmen defect is a bony defect, and it doesn't always come with a meningoencephalocele, but all meningoencephaloceles require a tegmen defect. So what are the causes of these tegmen defects? I think of them in 3 broad categories. The first category is iatrogenic, and this often occurs during middle ear or mastoid surgery.
It occurs sometimes with temporal craniotomies if people have hyperpneumatized temporal bones or if the craniotomy is put a bit low. And for those of you who do a lot of ear surgery, you know that bony defects over the tegmen are quite common and typically not a problem unless there's a dural defect as well. If you run into a bony and dural defect and brain tissue is exposed or spinal fluid is leaking, that needs a repair. And if you're comfortable repairing that at the time, you can do it. If you're not, you can always close up and contact a neurotologist and have them take care of that in a delayed fashion. Traumatic leaks are another, traumatic tegmen defects are another category. I think the most notable fact of that is in the short term that CSF leaks occur rarely with these, but if you work at a trauma center and see a lot of temporal bone fractures, you'll come across these. And these often stop with conservative measures on their own, plus minus a lumbar drain. Still, I think the seminal study in this field was done at UC Davis quite a while ago now, and it showed that there's very few patients who have a traumatic tegmen defect and spinal fluid leak that actually end up needing a surgical repair of that in the short term. And then finally, there are what I call spontaneous tegmen defects, and that is what we're going to focus most of our talk on today. So the incidence of spontaneous tegmen defects from cadaveric studies is estimated to be 6 to 22%, which is quite common. Why do these occur? We don't completely understand, but it seems like there's likely multiple things that can lead to it. And in most patients, they probably have a combination of factors that are what end up resulting in complete holes in their skull base. So there certainly seems to be some amount of a congenital disposition with either how the temporal bone centers ossify together or with the quality of the bone or the character of the bone. It's been shown that there's an association between increased body mass index with tegmen defects. The thinking there is that the increased BMI would cause increased intracranial pressure, and that over years that pressure pushing on the bone may cause it to thin out. Along those lines, patients with idiopathic intracranial hypertension seems to be a risk factor for this. If you see a lot of these patients, it's interesting in that there also seems to be some subclinical variant. I've seen a number of patients who you find that they have tegmen defects or spinal fluid leaks into their ear. You get an MRI and they have an empty sella or transverse sinus stenosis. You send them to neurology and neuro-ophthalmology for a workup for intracranial hypertension, and they essentially find they don't meet criteria for that. And so there's been a fair amount of work in this field related to the ear recently, and I think that we're going to know much more about this in the coming years. Chronic negative middle ear pressure seems to play a role as well. A lot of these patients, have this, and the thinking would be just like if you have chronic increased pressure from above, if you have chronic negative pressure below, that can wear on the bone, or if there's a defect, help pull the soft tissue down into the temporal bone. Prominent arachnoid granulations certainly play a role or are a frequent cause for spinal fluid leaks into the temporal bone. And what goes along with that are patients with hyperpneumatized temporal bones. And part of that may be that the tegmen is thinner just because of their extensive pneumatization, or there's more surface area with air directly below it where those arachnoid granulations can erode through. And then finally, two categories that aren't exactly spontaneous, but I'm going to put them in with it today, are prior ear surgery. And this I'm making a distinction from bone that gets removed off the dura during the operation. This is more like a patient who would have a mastoidectomy where that bone was thinned, and you get a scan a few years later, and there's now a dehiscence in the bone. And patients who have chronic infection, like otitis media or cholesteatoma, can certainly wear a hole in the skull base. So the problems that are associated with tegmen defects are meningoencephalocele, CSF leaks, conductive hearing loss, which often occurs from one of two reasons. One reason is if there's a meningoencephalocele that is sitting down on the heads of the ossicles, it dampens the vibrations. Or if there's a CSF middle ear effusion. Superior semicircular canal dehiscence, this seems to occur for many of the same reasons that the skull base may get thinned and you have dehiscences in other areas.
It's one of my favorite topics, and it could be a talk in itself, and we're not going to talk about that much today. And then finally, and a big one, is meningitis and intracranial infection risk that comes from losing that barrier between the ear and the calvarium. So how are these defects diagnosed? I have some things here that sort of trigger in my mind thinking about this, and you'll notice that a lot of these are much more commonly associated with other otologic problems. So in the history of a patient, if they've had prior ear surgery, a persistent serous middle ear effusion that seems resistant to other treatments, clear rhinorrhea, particularly when they bend forward or straining, prior meningitis, symptoms of intracranial hypertension like headaches or visual field defects. These are all things that you may hear from a patient with Tegman defects. On the exam, similarly, things like obesity, serous middle ear fusion, and what I call a positive head-down test. That's essentially the provocative maneuver where you have a patient lean forward with their head between their knees and keep them there for about 30 seconds and look to see if that'll elicit clear, thin rhinorrhea dripping from their nose. If they have hearing tests, they may have conductive hearing loss and type B or C tympanometry. But really, these diagnoses are made based on imaging and lab testing. And many of these are found incidentally when scans are obtained for other reasons. If you're looking for one, or if you want to characterize one, really the gold standard first-line scan is a high-resolution CT temporal bone without contrast. If you find a defect and you need to differentiate whether there is intracranial tissue that's coming down into the ear, then the follow-up scan for that is an MRI of the IAC or temporal bone with and without contrast. And I'll show some examples of these shortly. And as far as lab testing goes, if there's ear fluid or rhinorrhea that you're not sure if it's spinal fluid or if you want a definitive diagnosis, beta-2 transferrin lab testing is excellent. It has a high sensitivity and high specificity for CSF, and they only need about half a cc to run the lab test. And so if patients are leaking from their nose, oftentimes either in clinic or if you give them a specimen cup to go home, they're pretty easily able to collect enough of that for testing. For middle ear effusions, there are a few different ways to do it. Some people have had success with needle aspirations or making a myringotomy and using a suction collection trap. I haven't had a lot of success with that. I think that oftentimes the quantities of fluid in the middle ear are not sufficient for that. And so what I typically do is put an ear tube in, if they don't have one already, and then send them home with a specimen cup and a handful of cotton balls. And I tell them to keep the cotton balls in the ear, and as those cotton balls get saturated with the fluid, put them in the specimen cup and keep them in the refrigerator until you get a few of them. Once you get a few of them, call the clinic and give us a heads up. Put the specimen cup with the cotton balls on ice and bring them in, and the lab can wring out the cotton balls and usually get enough fluid to do the testing. And so I've had good luck with that. So let's look at some imaging for Tegman defects. High-resolution CT of the temporal bone, particularly coronal cuts, are what you're really going to look for to look at the skull base here. And these are best for detecting bony defects. So this is a patient of mine who had an endolymphatic sac decompression a number of years ago and had a canal wall-up mastoidectomy with that. And a scan was obtained for an unrelated reason recently. And here you can see in this coronal plane, this is the superior semicircular canal, the horizontal semicircular canal. And the tegmen should be this nice, smooth, contiguous line of bone above the ear and underneath the intracranial contents. And here you can see there's a gap of that bone. This one is pretty obvious. And notably, you don't see any soft tissue density underneath it. It looks like that's air underneath it. So in that case, from this CT alone, I was able to say you have a Tegman defect. It doesn't look like there's any meningoencephalocele or spinal fluid leak based on the imaging. The patient didn't have any symptoms concerning for that. And we said, okay, we've got this figured out at this point. We'll talk about management of these in a couple of minutes. This is an example of an MRI for a follow-up study. And what the MRI is really useful for is differentiating soft tissue density on the CT scan in the temporal bone. So there are many cases where you see a tegment defect and there's soft tissue opacity below it, and you don't know what it is. It could be effusion, it could be inflamed middle ear mucosa, it might be meningoencephalocele, could be cholesteatoma. And MRI is going to help you figure that out. The MRI sequences can be a little tricky, and so this is one, if you're ordering it specifically for this indication, you may want to speak to your neuroradiologist for the protocoling. But essentially you want to get multiple high-resolution, thin-cut coronal sequences. So this is a sequence, they come by various proprietary names, but this is one that basically has high resolution for brain tissue compared to surrounding tissue. And here you can see on the right side that you can see a nice smooth line of black underneath the brain, and that's the tegment of the temporal bone. On the left side here, this line goes out, and then you have an area where that black line is not apparent, and you see some soft tissue density underneath it. And on this sequence that looks similar to brain tissue, this is a T1 post-contrast scan. You can see that corresponding here, and that also looks like that's in continuity with the brain tissue. And so you could say this, based on this, you know that this is a meningoencephalocele. Here's an example from another patient. This is the CT scan of the left ear coronal sequence again, and you can see there's a dehiscence with soft tissue underneath. MRI was obtained, and again, this showed tissue that seemed to be in continuity with the brain coming down. I'm not showing it, but also diffusion-weighted imaging, which is helpful for finding cholesteatoma, and T2 imaging, which shows effusion, were all consistent with essentially brain tissue in the ear. Here's another example. This was a challenging case to figure out. This was a patient who came in with a conductive hearing loss and a deep epitympanic retraction pocket. So we obtained a CT scan, and here you can see, it's a little unclear. It looks like there might be a little bit of tegment here, that white bone, but it's certainly thin and maybe dehiscent. And there's soft tissue above the ossicles here, and it looks a bit rounded. And so to me, initially, the thinking here was this looks like this might be cholesteatoma that has eroded part of the tegment and is pushing it up. But I have a very high index of suspicion that anytime you see a tegment dehiscence and soft tissue underneath it, you want to think about the potential for an encephalocele or a CSF leak. So we got an MRI, and the MRI seemed to indicate that it was an encephalocele. Here on a T1 sequence, you can see that the soft tissue seems to be in continuity with the brain here with some blood vessels around it. And the diffusion-weighted imaging did not show findings consistent with cholesteatoma, and the T2 was not bright, so it wasn't an effusion. So based on this, we made the assumption it was encephalocele and treated her in that way. So for the diagnosis keys, I really think a high level of suspicion is required. And so, like I was saying, anytime you've got suspicion, go to the imaging. If you don't have a CT, start with a CT. If the CT is unclear, get it followed up with an MRI. The MRI is really helpful for differentiating the soft tissue components, and sometimes it helps localize a site of a CSF leak if there are multiple tegment defects. And then finally, if there's question about whether the fluid in the ear or the nose is spinal fluid, beta-2 transferrin is an excellent test. If it's negative and you have a sufficient sample, you can be pretty sure that it's not a CSF leak. If it's positive, you know it is. So once you have that diagnosis, I want to talk a little bit about the decision-making for how to treat these tegment defects. And in my mind, there's a couple of things where this really hinges on, and probably the most important is, what is the meningitis risk, or the risk of intracranial infection? There's really a limited number of studies that try to estimate this, and there's a wide range based on heterogeneity of what they're looking at. And so you have to extrapolate based on your knowledge from other conditions and come up with your own loose idea of risk of infection spreading up to the brain from the ear in these situations. And this is what I've come up with. In that if you see a tegment defect alone, like in that first example of the patient who had the endolymphatic sac decompression, I think that that's a low risk of meningitis. There are many of these patients out there. We know from the cadaveric studies it's common. We know from patients with chronic ear disease who we've operated on that a lot of patients have these and they're not getting meningitis very often. And so I consider that low risk. If there's a tegmen defect and a meningoencephalocele, I think the risk has gone up a little bit. If you add to that chronic otitis media or recurrent acute otitis media, or anything else that puts them at higher infection risk in general, immunocompromised, anything like that, now I think we're starting to get to more significant levels of risk. And finally, if there's a spinal fluid leak, we know that those patients have a fairly high long-term risk of developing meningitis or intracranial infection at some point. What goes along with this are, if you do cochlear implants or are aware of treat many spinal fluid leaks either in the sinuses or other places, there's CDC guidance about vaccination for some of the common pathogens that cause meningitis. And so if you ask the question, do vaccines decrease the risk of meningitis in this specific population, we don't have any good direct studies, but I think presumably it would. And so for me, for patients who are in relatively higher levels of risk of developing infection later on, I oftentimes follow the guidance for cochlear implants or CSF leaks as far as recommending vaccinations to reduce that risk. And so here's the full decision tree. The other part of that is dealing with the conductive hearing loss. And so what I start with is once that diagnosis is made, do they have a CSF leak? And if they do, I oftentimes recommend surgery to get that repaired because I think that that is worth going through that to try to reduce their long-term meningitis risk. If they don't have a CSF leak, then my next question is, do they have a meningoencephalocele with any of those factors that put them at higher risk of developing meningitis, like chronic ear infections? If the answer is yes, I oftentimes recommend surgery. If they don't have any of those factors, then the next question is, do they have conductive hearing loss from this? Either from the brain sitting on the ossicles, well, in this case, the brain sitting on the ossicles would be the reason, because if they have CSF, middle ear effusion, I would have said, yes, we should do surgery. And if they do, and you want to treat the conductive hearing loss, the patients then have an option. They could do surgery, or they could use a hearing aid. And this is like conductive hearing loss in many other situations, really a patient-specific decision based on their preferences. And finally, if they don't have any of those things, then at that point I usually say, this is fine to observe. I'm not too worried about this. We don't need to keep an eye on this with serial scans. But for all patients, you want to counsel them about red flag symptoms of meningitis or CSF leak. Tell them, if you get the worst headache of your life with a fever and sensitivity to light, you go to the nearest emergency room and you tell them that you think you have meningitis. And then you also warn them about the clear, persistent otorrhea, either from the nose or the ear, and that if that's the case, to call you and be reevaluated. And then I consider pneumococcal vaccines, again, based on what I think their relative risk is. So let's talk about surgical repair of these tegmen defects. This can be done through a couple of approaches: transmastoid, middle fossa craniotomy, or a combined approach. Both approaches have long track records of safety and efficacy, and they have their relative pros and cons. The transmastoid approach, I believe the pros to this are that it's low risk and low morbidity. It's an ear operation. I think the downsides to it are that depending on how you do the repair, if you're repairing on the inferior side or the ear side of the temporal bone, then gravity is often working against your repair. The intracranial contents are pushing from above. I guess if this is the hole here in the tegmen, it's pushing from above on the repair and trying to push it off of where it's connected. It can also be difficult to access medial defects, and if the defect is in the epitympanum, it may require removing the ossicles and performing an ossiculoplasty to get to that area and treat it. The middle fossa craniotomy, I believe the advantages to that are for experienced surgeons who use small craniotomies. It's also very low risk and low morbidity. It has excellent exposure to the entire tegmen. Gravity works with the repair because the repair is sitting on top of the skull base and the intracranial contents are pushing down on that and sandwiching it against the bone, keeping it in place. And an ossiculoplasty is not needed. So if a defect is right above the middle ear, you can get there from above, lift out the brain tissue, and put your repair there without touching the ossicles. In my mind, the real downside to it, and this is kind of an interesting one, is that in some places there are legal restrictions after craniotomies. So in the UK, there's a rule for that anyone who has a temporal craniotomy, regardless of the indication, can't drive for a number of months afterwards. So that's a good reason in the UK why they do a lot more transmastoid repairs rather than middle fossa craniotomy. Here in the States, I'm not aware of any of those restrictions. And so let's look a bit more at this operation. I think when I mention it to patients and I tell them it's a craniotomy, the first thing they all think is brain surgery, right? They think of patients being in the ICU afterwards and having defects and long recoveries and shaved heads. And so what I tell them is I tell them that it is a craniotomy technically. We're making an opening into the skull, but we're staying outside of the dura, and it's really much more like ear surgery than it is like brain surgery. And so this is how I do it. Here, there's a sequence of photos showing the approach. So this is a patient's left side. Their face is down here, superior is here, and here's their auricle. And so I use a supraauricular incision like this. It's curvilinear incision. And some of you have probably seen, may remember, and may do other larger incisions for middle fossa craniotomies, especially for tumor cases or more complicated cases where you do need to do sort of the whole half side of the head shave and a big soft tissue flap. But what we found is that you really don't need a big access to get to the tegmen. And we make the incision, come down to the temporalis muscle, take a piece of the temporalis fascia for grafting material, and then reflect the temporalis anteriorly out of the way so that we see the squamous portion of the temporal bone. We design a craniotomy flap here. The ones that I do are typically about 3.5 by 2.5 centimeters, so quite small. It's centered over the external auditory canal. And then we use an otologic drill to basically outline that and raise off the bone flap. And that gets our exposure to the dura here. We'll look at the actual repair on the next slide, but I'll show you, as far as patients' cosmetic concerns, when this is closed up, this is all in the hairline. There's not much hair shaved here, and so these heal up really nicely. And here's a video of the actual repair portion. This is a patient, this is their right ear, so anterior is over here, posterior is here. Let's see, I'm not going to use the mouse for that. This is their external auditory canal here, so superior is down here, and this is right above their ear canal. So this is the dura here. We've come down onto the tegmen and are gently elevating extradurally the temporal lobe and the tegmen, the temporal lobe and the dura off of the skull base. Incidentally, this is the same approach I use for superior canal dehiscence surgery, and the arcuate eminence in the superior canal would be right here. We're not going to see it in this video clip. But this patient had a defect over the epitympanum, and I think this is a nice illustration of the advantage of the middle fossa craniotomy. And so I'm gently dissecting the encephalocele out from the middle ear sitting on top of the ossicles, and we're seeing a bit of the head of the malleus here. There we go. And that's the entire defect exposed there. This is a magnified view, and so here you can see head of malleus. They're mobile. Anterior malleolar ligament. Geniculate ganglion would be up here. And tympanic facial nerve coming through here. So very cool anatomy, a little bit different view than what we're usually used to. So once you get all the defects exposed, the actual reconstruction, this is dural substitute material. I do an extradural onlay here, where basically you move this into place to create a complete barrier layer between the dura and the tegmen. The bone flap, I'll take a piece of bone from that. If it's thick enough, I like to do a sagittal split. Many times it's not thick enough, and if that's the case, I'll just cut a piece off of it and put that down to recreate a rigid structure on top of the skull base. And then this is some of that temporalis fascia to create a third layer. So it's a multi-layered repair. This is a little bit of fibrin glue to hold things in place. And then the craniotomy is closed. If I was able to do a sagittal split, I put the bone flap back with some mini plates. If not, I just use some titanium mesh to close the craniotomy. Postoperatively, the operation takes about 2 to 3 hours. Patients usually spend one night in the hospital for neuro checks. They often have very easy, smooth recoveries. Bad complications, the stuff that we think about and we consent the patients for anytime you're working near the brain, things like stroke, epidural hematoma, like intracranial infection like meningitis. Those are very rare with this kind of operation. And they have a high efficacy for stopping CSF leaks and improving conductive hearing loss. Long-term studies are lacking, but at least short-term and medium-term studies seem to show that these patients tend to do well and oftentimes don't have recurrence. However, there are some cases where they do recur or they have multiple leaks, and these can be some very challenging cases. Sometimes you see these patients with leaks in the ear and leaks in the sinuses. And oftentimes, what you have to do is you have to go back to the underlying cause and really aggressively treat that. So if patients are obese, you talk to them about weight loss, potentially bariatric surgery if needed. Investigate, and if you find it, treat intracranial hypertension. And then finally, for the toughest cases where sometimes there's just so much increased intracranial pressure and the leak is actually an outlet valve allowing them to regulate it, what happens is you patch it, their intracranial pressure goes up and they blow a leak somewhere else. You patch it and they blow a leak somewhere else. Oftentimes for those patients, you end up needing a ventricular peritoneal shunt for diversion. These are rare, but these can be very challenging cases to manage, and obviously you work closely with neurology and neurosurgery on these. And so that concludes my talk. It's 10 o'clock, and so I don't want to keep you all from the bathroom breaks and getting something to eat and seeing the vendors, but if anyone wants to stick around, we can answer, Dr. Kaufman and I can answer questions for a couple of minutes, or you can find us over the break, and we're happy to chat offline. So thank you very much.
So that was great. Thanks so much, Nick. So last call for turning in your bingo cards. We're going to do the drawing during the break and then announce the winners just before we start our final facial plastic session. So a few minutes to get those cards in. We got some great prizes. Really excited to give those away. I just want to take this moment to really thank all of our speakers. I think this has been just a terrific conference. It's great to see all of you here. I thought that really we've had some great talks, some great panels. I want to thank my faculty members. I'm proud of all you guys for a great job. I want to thank the visiting speakers for taking time out of their busy schedules to come share their expertise with us. Thank you so much. I also want to thank our administrative team. I think we all realize how much incredible work goes into ahead of time putting a meeting like this together successfully. I want to especially thank Sonia Romo, Tracy Blades, who couldn't be here but did a lot of the work as well. Michelle Eros, Angela Castillo, Carrie Hart, Brittany Lewis. Thank you so much for doing such a great job. And last but not least, I want to make a special thank you to the man behind the camera there. Chris Adams is not only a physician assistant extraordinaire and member of our academic faculty, but he put a lot of thought and work into making sure that the AV support during the meeting was absolutely flawless. So thank you so much, Chris. It's also his birthday, so wish him happy birthday. And I know your wife has special plans for you tonight, and you certainly deserve it after all the work you've done the last 3 days, so thank you so much. But in any case, so again, it's not done yet, but thank you again. If you're traveling, safe travels. We certainly hope to see you again next year, and then looking forward to the drawing and the final facial plastic session just after the break.
Thanks, Steve. So Dr. Kaufman and I will stick around here for a couple minutes. We'll just take questions offline. Hey, what's up, Clay? How you doing, man?
Good. How are you?
Good. Nice to see you.
I wanted to ask Dr. Roush, but I think it's actually probably better because I don't for the vestibular migraine patients.
Yeah.
Are you doing any of the preventative stuff?
No, so this is actually a
Like,
great.
send them all to neurologists.
No, you know what? This is a great question, and I kind of wrestle with this myself a little bit. I think that part of it is there are a huge number of classes of medications for migraine management, and I'm not that familiar with them, and I don't really want to become all that familiar with them and stay on top of them. And so what I do is I send them to neurology, which is frustrating because of numbers of reasons. It's an extra referral for the patients, and neurologists have varying levels of sort of awareness or belief in some of this vestibular migraine stuff, and so it's challenging. But Dr. Roush, for example, he will do one drug at a time, but once it gets more complicated than that, he'll send them to neurology. But
Yeah, because that was my thing. Is there's so many ones
yeah.
that you could try. It's like a plug and play, you know?
Yeah, it is, and I mean, I think it's something if you have an interest and you want to learn about it and stay on top of them. I think it's actually great for patients to do. But I think that as far as my practice goes, I don't have the brain power to devote to that. Yeah, I tend to send them neurology or sometimes primary care doctors. If they have a good primary care doctor, I'll tell them, talk to your primary care doctor about getting on some migraine preventive medication. He's awesome. He's awesome. Yeah, he's really good. Yeah, and he's a good speaker too. So, yeah. Thanks, Clay. Hi. Yes. Yeah, nice to meet you in person. Yeah.
Like homemade burgers and fries.
We sure did.
Our little air fryer for fries.
We are. We're gonna peel that one, and we'll, just like you said, we'll push it up.
They're so popular.
If we get it approved,
Yeah,
great. If we don't, at least it's
It was good for
another
the fries.
one going up the chain.
She made a big batch, so we had half in
Yeah.
the air fryer and half in the stove. And like the oven, I should say. Yeah,
Okay.
the oven's kind of sucks. Yeah. Alright, yeah, it's good.
Review. Okay. Okay. Yeah, we have to jump to Luke. That's fine. We'll do that. And so,
So I can put theirs in my
Otolaryngologists I work with in the system are trying to get this changed.
yeah, takes time,
Higher ups
right?
don't listen to the
Right.
opinions.
Yeah. Well, I very much appreciate your help with that and advice on that.
Well, we're strong advocates, believe it or not, for the patients. We
Right.
just have to do our job where we
Yeah.
do
Yeah.
it. So that's why I'm happy to give you that kind of information.
Yeah.
To be able to get it
Sounds good.
Yeah.
And I have another question.
Yeah.
If you don't mind.
Certainly.
Briefly, if you don't mind, what's the standard workup for
Yeah, that's a
What
good.
are your indications for surgery?
Yeah. So that's
Oh, we have to, yeah, we'll have to plug it in to check it out.
yes.
Sometimes
So
we'll
that's a really good
forget,
question. So
yeah, it should be no big deal.
well, as far as let me start with workup.
Okay.
So usually, if I have a suspicion that somebody has superior semicircular canal dehiscence, I'll get a CT temporal bone first. Sometimes that's how it's found initially. A CT was done for another reason, and it's an incidental thing. And then they'll come see me, and I'll talk to them about whether they have symptoms or not. If they have a dehiscence on CT scan, and they have symptoms that I think may be caused by, yeah, exactly, or a sort of auditory, pulsatile tinnitus,
Yeah, these should all
autophony.
be good.
Then the next step is I'll get a VEMP test. Yeah, because VEMPs are very.
That's about the only thing that's going to show you.
Yes,
But
exactly.
Vamp is full, right?
Exactly. That's the main thing I use it for.
We get for Vamps for stargazing kind of stuff.
Right. VEMPs are actually, I think we're going to see more of them used in the future. They're actually a pretty good kind of quick and dirty test of vestibular function. So I would also say that, I would put them sort of in the same category of VNG a lot of times. In that, yeah, if you don't have same with VHIT. If you don't have a rotational chair, which a lot of people don't, including us, then oftentimes what you can do is you can sort of patch together, like a VHIT, VNG, VEMP, in some combination, and that'll give you a pretty good idea of each ear's vestibular function.
Right, but the main thing I use it for is determining whether there's a third window, like SCD. And so I get the vent testing, and if the vent is consistent with a third window, then what I tell the patients is I say, hey, listen, SCD is not dangerous. You know, this is not something that I'm going to tell you need to repair. It's totally based on you and your symptoms. You know, if your symptoms of, you know, whatever ones I think are attributable to SCD are so bothersome that you would want to go through, and then I usually tell them about the surgery and like the risks and basically the success rate with it.
Open them all up.
I try, that's my preferred approach. There are certain cases where the dehiscence is either sort of behind a corner, like sitting behind the arcuate eminence, or underneath the superior petrosal vein, where it makes it so you can't get to it through a middle fossa, and in those cases I'll go transmastoid. They're both reasonable approaches. I just think same with the tegment defects. I just think that the middle fossa is technically easier, and I think the patients oftentimes do better. So I do plugging, canal plugging, which is I think really the gold standard for treatment.
Okay.
There are some people who will do things like round window reinforcement or resurfacing, and so like for example, if you have the dehiscence, what I'll do is I'll come in and I'll basically put bone wax into the canal to occlude the superior canal.
Really?
Yeah.
It doesn't cause any issue?
It does, but oftentimes the issues are pretty mild compared to what they have. And so if somebody's got a pretty healthy vestibular system in both ears, and you occlude the superior canal on one side, they usually compensate and do really well. Yeah. There are some people doing resurfacing. Early studies of that showed that it just didn't, you know, empirically, you would think it would work, but it doesn't work as well. And round window reinforcement, I think the same thing. I think that we're seeing empirically that that doesn't really get it done. It also doesn't make a lot of sense from a mechanism. So I love SCD. In fact, I was thinking probably next year I'll give a talk on it.
Well, because I get requests for it, and they're iffy.
Yeah.
The whole thing.
Do you get requests for the workup or for the surgery or both?
Surgery.
Yeah. It can be, yeah. So, I mean, I think I require, for my requirements for surgery are you have to have a radiologic dehiscence. Well, no, you know what? I actually take that back. There's a weird phenomenon where there are some patients who have thin bone and they have the syndrome and get better. We don't know how to explain it, but we do see it.
That's what we're seeing.
Yeah.
Is, you know, can be consistent with SSCD on the CT scan.
Yeah.
It doesn't tell you.
You know what in my mind the answer to that is the vent. Is that if they have the abnormal vent, usually I'm pretty comfortable saying, you know, you've got an active third window, and you know, this is something that makes sense. If the vent is normal, then I usually won't offer surgery. You get to some real hard cases where people have middle ear issues too, because then the vent becomes sort of challenging or impossible to interpret. But those are pretty darn complicated cases.
Because I see those, and I see a lot of, well, not as much as anymore, but paragraph fistulas.
Yeah, I'll come down and join you here. Yeah, so yeah, paragraph fistula, you're probably more familiar too with that story, right? Is that, you know, I think that back in the day, people didn't really know as much about SCD or vestibular canalers. All of these patients who were busy with explorations, and you know, the results were
right, so this is the moment I know we've all been waiting for. I have the winners of the fabulous prizes that we're offering. And let me just take a moment at this time to once again thank our sponsors for their generous support. This meeting wouldn't have been possible without all of you. Appreciate that. Thank you for being there with us, actually for the last several years, and particularly in this meeting. But in any case, I have the list of our winners, and so I'm going to start out with, we're giving away 3 t-shirts. So these first 3 are winners of a U of A Wildcats t-shirt, and the first t-shirt winner is Adam Gardner. And then another t-shirt winner is Mark Mount. So you can collect your prizes over with Sonia. And our third t-shirt winner is Amanda Sweetland. I heard you got that in just in time, so that's terrific. And now moving on to the really, really big prizes. Our third place is a Wildcat pack, and so it comes with all kinds of great University of Arizona Wildcats gear. And the winner of the Wildcat pack is Sarah Lim. And then for our next award, which is free registration at our ENT and Desert Conference in 2023, and that goes to William Kluge, which is great. I know William has been a attendee of our meeting for the last several years, and so great to see that. And now our grand prize, which includes a 2-night stay at this fabulous Lowe's Montana Canyon Resort, goes to Jeff Nelson. So congratulations to all our winners. And then just as a final reminder, make sure to turn in your feedback and survey to Sonia to get your CME credit. So make sure you do that before you leave. And now we will move on to our final session of the meeting. Our facial plastic sessions will be run by our Director of Facial Plastic Surgery in our department, Dr. David Chen.
Thank you, Dr. Wong. So welcome to our final session for the conference. For those of you whom I haven't met, my name is David Chen. I'm the new facial plastic and reconstructive surgeon here at the University of Arizona. And when I started here back in September and found out about this conference, I had asked Steve Wong if we could save the best subspecialty for last, and he said, sure, why not? So here we are, really excited to have all of you here. We have some fantastic talks lined up for you today by speakers who, some of whom are from here locally in Tucson, and some of whom are visiting as our friends from the not too distant north at Mayo Clinic, Phoenix. First up is going to be Dr. Brittany Howard, who is she is the chair of facial plastic, Division of Facial Plastic and Reconstructive Surgery at the Mayo Clinic, Phoenix. So without further ado, Dr. Howard.
Thank you, Dr. Chen, and thank you for having us here. It's really a privilege to be part of this conference. I've been attending for years, having done my training here in Arizona as a resident. I did fellowships in head and neck microvascular at University of North Carolina, and also in facial plastics and reconstruction out at UNC before coming home. I've been at Mayo back for about 5+ years now. So one of the things was, in coming back to Mayo, I had a chairman who really believed that bringing a facial plastics division into an academic practice would be a profoundly positive thing. And I have obviously been fully converted over that. He convinced me and supported me in doing a second fellowship, and want to share kind of what we found in 5 years of reintroducing it, not just as something that was there. Dr. Bansberg, of course, and other colleagues have been there carrying the facial plastics torch for decades, but growing it up a little stronger, bringing it into a true division, and continuing to add faculty. So with that, I don't have any disclosures to make. Hopefully we actually will shortly be updating that. This is my background of why I feel like we can get up here as a center and talk about this. And it doesn't just apply to facial plastics and academics. This is really something that I believe and I was trained in when I was out at UNC. I had mentors that were both private and academic, that facial plastics amplifies any practice you put it into. So to give you an idea, in our first year I came, again, was double fellowshipped, and so I came on and we said, hey, it's gonna take a while to grow this. Same way as someone going into private where, you know, they're gonna start doing quite a bit of general while they grow their practice. So I was maybe 25% facial plastics in my first year, mostly doing head and neck, lots of reconstruction, and as we all know, reconstructive patients have a tendency to become cosmetic patients later on many times. By year 2, I was doing facial plastics only. We were completely overbooked. I couldn't keep up with my head and neck, and I couldn't get head and neck patients into ORs fast enough. And we started seeing the 6-month wait or more for surgeries. By year 3, my RVUs were at greater than 220% of the national median for otolaryngologists, and we had a wait list for clinic and OR that was beyond what Mayo allows for booking. So there was just a paper wait list sitting somewhere. Which means that in year 4, we've got $200,000 in grants for regenerative medicine, facial plastics research. We've opened a multidisciplinary cosmetic center that involves multiple other specialties. We've gotten the okay from Mayo, which is a profoundly conservative institution, to hire another facial plastic surgeon. And I'm delighted that we have Dr. Grunebaum now on faculty. She started this week. Has a 15-year history from another academic institution and bringing her expertise to Mayo. And so what we're looking at through our year 5 is that we currently have offers for 3 industry-related clinical trials, and we are initiating the paperwork through Mayo for starting a fellowship. So what we found there is that, gosh, there's all this growth potential and so many opportunities. And it's because of this basic idea that anytime I think you bring in a new specialty, but especially facial plastics, which I think has a lot of flexibility, we're a generally agile group of surgeons, as are ENTs in general, where we bring in new treatments, new collaboration, and opportunities for research, and research that is heavily industry funded, which can be a fabulous boon both in academics and in private practice, and quite frankly is easier to pull off in private. So the things you'd expect, right? You bring in your facial plastic surgeon and they're gonna do rhinoplasties and they're gonna do facial aging and cosmetics and they're gonna enjoy reconstructive surgery. So this is an example of one of my nasal reconstructive patients to kind of get that idea. And this is what we expect. So I am gonna touch on this briefly because I think it is an important component, but I think it's actually not the most important component. It's the things that come after that that are big. So you do expect that you add in a facial plastics person, and this is what we really enjoyed growing at Mayo, was going from just our functional nose patients, which we had long been supporting and caring for, to add on that cosmetic component as well. Beautiful girl, and you know, the beauty of rhinoplasties is not meant to change the face, it's not meant to change the person. It's just meant to take away if they have a distracting feature, such as an unfortunate nose, which she has an unfortunate nose. And is distracting from how gorgeous she is. And quite frankly, she can't breathe. And with that horrific caudal end, I don't think that there's that many people that would think that you're gonna get a truly good breathing result without doing an open, pretty comprehensive surgery. She actually ended up, when I opened her, having a complete congenital absence of all of her cartilage on the right side. She had a medial crura, and that was it. She had no lateral crura, she had no intermediate crura, she had no upper lateral cartilage on the right side. And post-operatively, this is her 2-year result. She breathes well, she's happy with her aesthetic, and we did that with an ear cartilage graft and a septoplasty and an open approach procedure. Similarly, you're gonna expect to see aging face grow. It takes a little bit of time. This is a unique patient population, but it does definitely grow and come. Even in an academic institution where I'm not allowed to advertise and I can't have a social media, it still grows. And so this is our typical aging face for me. This is someone who's 80 years old. She's had a prior facelift and she looks pretty good. And so, but she's really bothered by some of the redundancy at her neck and some of the heaviness along her jowline. So for me, she doesn't need to go to OR. And so this is where I think that you can especially leverage this into private and academic practice, such as during COVID. I don't need an OR, and I'm not going to generate an inpatient stay, which doesn't burden my hospital system, which means my cases get to keep going. So I did this in clinic under local sedation and tumescence, and we did a facelift. This is her at her 2-week mark. She still has a little bit of bruising on the right side and a little bit of fullness and submentum from her mental incision. But she's very, very happy. We wanted to bring this since doing stuff under local is a little bit less common anymore, and I think that we have a little bit more tendency to go to OR, but it's not always necessary. And with that cosmetics practice, the true cosmetics component. At Mayo, we just opened a multidisciplinary cosmetics center, and the best part is that it's a collaboration between divisions. It's not an isolated event. So we are with plastic surgery and cosmetic dermatology, and it's huge for us because Mayo doesn't advertise. And so you get word out by buzz and personal recommendations from one person to the next. So anytime you look at a practice where you don't have a significant advertising budget, if you add in another practitioner, you make more buzz and more word gets out and it grows faster. I think that there is always a concern of, gosh, I'm going to add in someone else, such as plastics, when they hear you're going to add in a facial plastic surgeon, and they're going to take away some of my patients. They're going to take from me. And that doesn't happen. We all know how busy we all are. All it does is it creates more buzz, more positive reviews, and more patients coming in wanting to meet you and your amazing staff. So in the 5 years that I've been at Mayo, plastic surgery has added 0 additional human beings. They are the exactly same number of surgeons. They have increased their bottom line from a negative 25% to a positive 12%. That's not because I did something, but I certainly didn't take away anything by being there. What we saw is an overall growth of the entire practice. And so there's no reason that bringing in another person kind of takes from our colleagues. So with that, it lends naturally to collaboration. And so suddenly you have someone that's next door that you can go and knock on their door when you have that slightly more complex patient come in. I'm lucky in that I work with Dr. Amar Meglani here, who's one of our fabulous rhinologists, and I know that when I have the patient that comes in with that nasal obstruction and chronic sinusitis package, and yeah, they need a functional or they want a cosmetic rhinoplasty, that I've got someone I get to go knock on the door and ask for sinus expertise. Similarly, when he has a sinus patient that goes, oh, and when you do nose surgery, like that's gonna straighten out my nose too, and it's gonna look real pretty, and he has to explain that no, that's not what sinus surgery does, or no, that's not what a standard septoplasty does, but I have a friend next door, and you don't lose that patient to an outside practice or to a second practitioner, and you can offer to treat them comprehensively. It's really a wonderful thing. Additionally, you have this new option of facial reanimation, which is a very big buzzword, and I think that adding in facial plastics does an amazing job of bringing those patients in, and they have a lot of needs very often. And then lastly is to touch on functional Botox as opposed to cosmetic Botox. So the other ones are givens, and we recognize that, but this is what I would always remind people of why it's worth bringing in facial plastics. We play with Botox all the time. We love it. We like to put it in ladies' crow's feet and their smile lines. It does great, but it has a lot more uses, and it applies across the broad spectrum of ENT specialties. And I would claim that any person that's in a general practice or a head and neck practice sitting here today could walk out and take this and do this. We as ENTs know the head and neck musculature better than anybody else. We certainly know it better than the neurologists, and there are no neurologists hopefully here, so I can't offend anyone by saying that. But there are approved indications for Botox in the head and neck that are currently undertreated and underutilized, but can have huge quality of life improvements for our patients. So, of course, we know hemifacial spasm, and this is one where, for our patients with synkinesis after, sorry, it's going to keep clicking by, for synkinesis after Bell's, whether it's synkinesis after recovery of a facial nerve from an neurosurgical surgery or a neurotology surgery, or recovery after a head and neck procedure, we can certainly see this very powerful effect in improving their quality of life. So this patient actually has fibrous dysplasia. He's had innumerable surgeries on his right eye. It's resulted in a weak orbicularis on that side. It means he has dry eye, which means that he wants to blink all the time, which actually means that due to Hering's law of equal innervation, he's sending the message down to orbiculus oculi on both sides, and he's squinting his good side, his left side. And with that, he also is compressing that brow, and it's creating this very asymmetric facies. And so a little bit of Botox can go a long way. So this is him, and so I see him every 3 months. We put in about 50 units of Botox, and for him, I can't return his orbicularis function, but I can make him feel much better, and he loves this. And I spend probably 1 day a week just injecting Botox functionally, which this is something that we kind of know and accept, but how many people have heard about it or considered using it for torticollis in their head and neck patients? Is there anyone down here that's doing that? I haven't found many people. There are a couple different centers across the country. But recently, the AAO-HNS and Medicare agreed that torticollis is present post-head and neck surgery and post-head and neck radiation, that is acquired torticollis. Our patients after head and neck surgery that have those horribly spasms, sternocleidomastoid muscles, the traps that give them problems, all of that fibrosis from the radiation, that is a form of torticollis and is appropriate for treatment with Botox, especially if it has failed physical therapy or other indications. The requirements are that your patient has symptoms of 2, neck pain, spasm, limited range of motion, or abnormal head position at rest, which is, again, I also am fellowshipped in head and neck, and I do micro. I can guarantee you, as most people that I ever did a microvascular reconstruction on. So there are several good studies out there. There's small cohorts, but in general, what you see is that improvement for patients is in somewhere between 75 to 87% of patients treated with Botox in their spastic head and neck muscles report a significant improvement in their quality of life. And for those of us that have treated our head and neck patients, we know that a lot of times once they get out to that 5 years, the one thing that we still are seeing them for is that they have chronic pain, they have chronic tightness, and it's that sequelae of treatment that really is affecting them. And so to actually have something to offer them is huge. So we do this predominantly for our institution in the facial plastic surgery division because I'm the most comfortable using the Botox, but any of our head and neck surgeons are fabulous with the head and neck musculature, and certainly if they did the surgery, know what areas are probably the most problematic as well. So there is a specific CPT approved for this as well as isolated ICD-10 codes. You are able to charge for Botox administered, Botox wasted, your EMN code, and a CPT code for that, which means that on average for us, I'm injecting about 200 units per patient. At Mayo, the medical charge for Botox is $25 per unit, which means that it's about $5,000 I bill out for a 30-minute appointment. And quite frankly, I can do the treatment in 15 minutes, but especially for counseling, we generally book these out at 30 minutes. Assuming I actually have a physician assistant that's really passionate about this, and so she has a calendar. If we treat 10 patients per week, and assuming that 30% are Medicare, and that I only collect on 47% of the cases, which is a profoundly Mayo conservative number, by the way, because you can always also get these prepaid or pre-approved, then what I make is actually $75,000 a month for my department on top of anything I'm doing in the OR or cosmetically, and it works out to $1 million a year. And that is currently what my PA is bringing in when she does her Botox, when we fill her calendar for 10 patients a week. Additionally, of course, if you bring in someone like this, we have this option then of research, not only as an individual, but especially with collaboration. So that entire topic is a hot topic that's ready and waiting for better research out there. Again, the cohort studies and that is out on torticollis is relatively low. There's few centers that are currently doing this. And so kind of jumping in and wading your toes into there and doing these quality of life studies are low-hanging fruit with a lot of potential for landmark studies. Additionally, facial plastics automatically translates well into regenerative medicine, which also is a hot topic and actually has its own area in NIH now. And so regenerative medicine for us is defined as anything that restores the form and function that was previous to a person from an earlier age or earlier state of being in their life, which is the definition of reconstruction. So when you think about that, it's any of those steps you're moving forward in reconstruction can be rolled into this, and it's very appropriate to be writing on and discussing. And so again, this is our Mayo Clinic definition. This was also published at the AAFPRS about 5 years ago as a definition of regenerative medicine. And it can be in many different ways. True translational research out of the lab, which is I work with 3D scanning and printing and planning, fat and stem cell transfer, laser treatments, and surgical innervation. So to leave you with that idea of that collaboration and multidisciplinary work, I'll do one quick case because I think he is a powerful study. Total nasal reconstruction in general is what I love doing. And so when I was at UNC, because I was the PERMA fellow and I had been the head and neck fellow and I'd been the facial plastics fellow, it meant I got to bother all of my mentors and try to convince them to do odd things. So we really wanted to tackle total nasal defects because it was very common for UNC. And we did the first medial femoral condyle flap here in the US. So this patient has this defect. After a forearm free flap, we at least closed off his mouth from his nose. And we started making a plan on how on earth do you rebuild this nose. So we went to his medial femoral condyle, take out a skin flap and a bone flap with heavy perichondrium. A huge problem has always been lining of the nose. You can use the perichondrium from the medial femoral condyle inside the nose, which mucosolizes much better than putting skin in a nose, which we all know skin inside noses doesn't do well. So we then use the bone from the medial femoral condyle to actually remake the nasal pyramid, and we put the skin on top as a babysitter since, again, we'd never done this. We'd done cadaver studies. No one that we knew had done this, and the person who published on it was in Austria, and so we weren't sure if this was gonna work, and we weren't gonna risk our paramedian over a potentially failing free flap. It went very well. It actually was very easy anatomy, vascular territories and reach was excellent. And we let him sit for about 3 months while everything revascularized. Then we went in, did our paramedian, put in additional cartilage grafting. I was back home and here by then, and so this is the picture that my old fellowship mentor sent me the day that divided his paramedian, going, it looks great. And it's like, that looks blue. But it does do great, and even paramedians that look blue right away do fabulous. And this is him afterwards. He's continued to have couple of further touch-ups and does well, and his nose functions and he breathes, which going from a total nasal defect from here to here is really powerful, and it's very uncommon to have teams that you can convince both of them to go out on a limb and both do something they're uncomfortable with. Facial plastics was not comfortable, having not a radial forearm inside the nose. Head and neck was not comfortable doing a flap they'd never used before, but when you have that bridge and you have everyone inside a same department working together, and especially growing together, you can tackle these very interesting and innovative surgeries and research questions. So I always say that facial plastics thrives in any place you put it, in academics, private practice. It's a wonderful addition, and we really enjoy being there and helping our colleagues with all the problems from functional quality of life, cosmetic, reconstructive. This is kind of the basis of facial plastics and why we further subspecialize, but at heart, we're all ENTs. So thank you so much. I really appreciate y'all giving me time up here.
Dr. Howard, thank you so much. That was an awesome talk and especially useful for someone like myself who's thinking of ideas and how to grow a division. So that was wonderful. I'm just going to hook up my computer here. Next up, we have Dr. Jerry Olson. So Dr. Olson practices here in Tucson at Foothills Dermatology and Facial Plastics. Let's see. He has been amazingly supportive and nothing but kind, and just my first 6 months here, so it's a pleasure to have him here. I'm really glad we could get him to come and give a talk today. So that pointer's hooked up to the computer. You can advance. There's the nice.
David, thank you very much for asking me to give a presentation today. So I practice here in Tucson. I've been in private practice now for well over 20 years, and for the last 14 in a practice with dermatologists. And as you pointed out, facial plastics can fit into a lot of places. My practice currently probably 60 to 70% cosmetic, the rest reconstructive, mostly skin cancer. I was doing trauma care at the university for years, but have given that up. This talk more about what would kind of fit into a general ENT practice than avoiding pitfalls. I'll certainly talk about the kind of things I've learned along the way to make things easier. But again, hopefully these are things that you can incorporate into a general ENT practice. I have no disclosures. So we have space in the office, which is nice. We have 3 treatment rooms where we can do surgical procedures under local anesthetic, and have really made good use of that over the years. I do a range of things in the office. All the upper eyelid surgery I do, unless it's combined with facelifting, gets done in the office. A great deal of skin cancer reconstruction gets performed there too. I've done implants in the office. I don't do them often. Small revisions of rhinoplasty I've done, including some open procedures. I do lip lifts in the office, and then there's always, from the dermatology side of the practice, kind of lumps and bumps that get done there. But there are times when that's not a good idea, depending on the patient, depending on how I feel about it too. So this is sort of my general selection criteria for all cosmetic patients, not just people I take in the office. So this is the avoiding the pitfall part of the talk, right? So you can have trouble along the way, but if the patient's reasonable and you're going to get through it. But the worst complication, I think, is a good result and an unreasonable patient. So if you can head that off in the beginning, you're way ahead of the game. So the general things are patients I don't like. You've all got your list of things that you don't like, and maybe it's just a bad day, but there's some telltale signs. Patients my staff doesn't like. That usually means people who are, rude to my staff or mean to my staff. I've had the same medical assistant for 14 years. If she says, yeah, I don't know, then that's usually something I should listen to. And then the patient where you're just not on the same page. You're describing what you think is the issue and what needs to be accomplished, and they're pointing to something else. It's just better to walk away. So these are the kind of general things I use to get through procedures in the office. If people are anxious, and we talk about that ahead of time, then we use Ativan. I used to prescribe Valium. I think Valium hangs around too long. A lot of the patients are older, and certainly any of these drugs can cause people to be unsteady, and you don't want your 7-year-old patient at home stumbling around. I do tell them to take it at least an hour and a half before they get to the office. We use buffered lidocaine. Some people do better with Marcaine. We ask about that ahead of time. If it's a bigger procedure, like we're doing a direct neck lift, I will mix wide ACE in with a local anesthetic. If you've never used it with local, it really helps to diffuse the local anesthetic much more thoroughly. It's, it used to be dirt cheap, but it's still relatively inexpensive. And then I use TXA, not for smaller things, but again, if I do a direct neck lift, I'm doing a larger area, I'll use it in the local. And there's good evidence in the cosmetic literature, facelifting literature, that it seems to decrease intraoperative blood loss. The side effects of TXA given intravenously are close to zero. You give it subcutaneously or with your local, no side effects to worry about at all. And then I learned this from Steve Diana, a well-known facial plastic surgeon in Chicago years ago. He gave a talk and mentioned using a massager when he injected local. If you've never tried that, it's a miracle. So these are little massaging things that I bought from Brookstone like 14 years ago. They're $20. We still have them. I put an exam glove over them so we don't have to sterilize them or clean them later. And if you hold that on the area when you're injecting, you can inject a lot of local anesthetic without hurting somebody. And if you get past that, the rest of it's easy. So just a couple things about instrumentation. We use bipolar cautery on everybody. It's just easy to recycle that stuff. If you use bipolar cautery, you don't have to be as concerned about a pacemaker or defibrillator. Again, a modern pacemaker defibrillator, as long as you're cauterizing intermittently and not for 30 seconds in a row, there should be no issue at all. I bought one of these a large instrument magnet that you've seen for bigger cases, and we just cut the little squares and throw them in the pack. And that way I can keep track of the needles during the procedure so we're not hunting for needles after 20 or 30 minutes operating. The downside of that is that as soon as you put a needle on there, it gets magnetized, and then that's annoying. So this needle driver is titanium. It comes from a company in Houston. They're reasonably priced, and they're really great. And they make them in smooth, which I prefer, so the Webster-style needle drivers. And then I use micro-Adsons, which are the same size as the 0.5s you might use for eyelid cases, but in a length and a feel that's more familiar to, I think, us. We don't use antibiotic ointment on sutures afterwards. You know, a fair number of people will have a cutaneous reaction to any of the topical antibiotics, neomycin most likely, and you just don't need it. Keeping it moist is the only important thing. We get sutures out early, and then to almost every incision, I apply Duoderm when the incision comes out. We use the thin stuff. We send more home with the patient. We have them change it weekly or so. I think that first 6 weeks of wound healing, that's when you can do something to a wound to make it look, to make the scar look better. So these are the 4 things that I would talk about, and I think 3 of these would easily fit into any general ENT program, or practice rather. The lip lift, maybe not so much, but you know, these patients are in your office all the time, and if you ask in the right way, they might be interested in these things. And I find these procedures fun and rewarding. The first is earlobe reduction. Now, this might be one you'd have to ask about, but you know, we kind of see them in 2 varieties. The next patient has kind of congenitally large earlobes, which have gotten a little larger with time, and she's never had anything done with them, but as she ages, they've elongated too. And if you start to talk to patients about earlobes and earrings, you discover this is a really, really important thing in their life. So I do the following reduction. This came out of a textbook that's been long out of print, written by a plastic surgeon named Davis. If you can ever find the book, it's great because there's a lot of reconstructive elements to that text, things that are hard to find, and he wrote extensively on reconstructing all kinds of ears. But there's lots of ways to reduce the size of an earlobe, but this is my preference because I think the earlobe not only it descends, so it needs to be brought forward and up. It's really a lift, and so this incision allows you to remove tissue in this superior and inferior direction, and also anterior posterior. That's what the incision looks like, and that's what it looks like when it's incised. And then I just kind of, you know, remove a little bit and bring it up and see how it looks, and remove a little more. Occasionally, when you get a really kind of ptotic earlobe like this, you'll wind up bringing the earlobe up here and having a little redundancy back down below it where it was attached. You can just repair that directly, and that scar just disappears. And then we'll wait, you know, 4 to 6 weeks and re-pierce them. That's easily done. You know, we make a mark, we all kind of stand back, and I hand the patient a mirror, and we all agree where that should go. A little drop of local anesthetic, and then I go from the backside with an 18-gauge needle. You can always get it into that mark every single time. And then the earring goes into there, and that gets removed, and off they go. This is her afterwards. This is really early on, but you can see this hides under the shadow of the antitragus and right against the cheek, and it's a really forgiving incision. The other side. So I put this in here just to show 2 things. One, how well this incision heals, especially in a younger person. And 2, you know, one thing I've always struggled with in some patients with otoplasty is you'll recreate that anti-helix, you'll bring the auricle into a nice position, And in some patients, they've got a large or a real prominent earlobe that juts out from the side of the head. There's lots of ways described, or at least a few ways described to deal with that, and I've never had any good luck with any of them. But you can make that earlobe smaller and less prominent, and the incision is really forgiving. So I think it can be a nice adjunct to that procedure too. So these patients get to me sometimes by word of mouth, but also a lot of these young people are on their way to the armed services, and of course they're not going in looking like that. So a couple of local recruiting offices, I don't know how they found my name, but they'll send these young people fairly often. And this is, I think, the easiest group of cosmetic patients, period. Long-term follow-up, it's non-existent. You know, sutures come out, they might come back for one more visit, and then I never see them again. They're not picky because they've been living with this for a long time. It's not like a rhinoplasty patient population. And, you know, if you think this looks, you know, eye-catching, you should see it with a hoop out. You know, the thing's dangling down here. It really is eye-catching. So it's an easy fix because there's lots of lobe, right? So you numb them up, you cut it down the middle, and then you just kind of start piecing things together. I usually start at the top and work my way down, remove a little bit, take a look, remove a little more. When I'm happy with the size of the lobe, I'll put a little Z-plasty at the free margin just to prevent any notching, and you get a result like this. This, you know, you can see his incision's still red. This is my longest follow-up photo ever. So it's surprising they came back even a month later. This is the next group of patients that I really enjoy taking care of. You know, a gentleman like this comes in the office, he's concerned about this. I say facelift, he says, that's not gonna happen. He says, just get rid of this. Can't you just cut it out? And I go, well, yeah. So this is a great article, describes all the incisions. We do it in the office, we do it in our local. There are multiple incision designs in that article. The most commonly used, I think, is the Grecian urn, which, you know, is more of a curvilinear kind of incision here. The idea behind that incision is you're sort of treating the expected dog ear as you repair it, because the Z-plasty is going to elongate the incision. This incision, this kind of H-shaped incision, works better for me. It's simple to design. You design your Z-plasty up front. And there's several steps that I'll take you through, but it's a pretty straightforward procedure. So there's the design of the flap. The Z-plasty should line up here at the cervical mental junction, which is roughly hyoid level. After skin's incised, I will remove supra and intraplatysmal fat, just like we do with facelifting. I'll plicate this muscle, and then I'll tack the platysma down to the deeper muscular fascia right at this hyoid level, because I think it makes a nicer kind of angle in that region. I do that with facelifting as well. That's, you know, intraplatysmal fat, or subplatysmal fat rather. And that's a diagram of the plication. I'll do a back cut here. I'll often come down here and excise a little bit here if it's prominent. I get the Z-plasty part of it closed initially, and then worry about kind of dealing with the dog ear up here and up here. That's closed. That's what it looks like on the table. He's probably 6 weeks or longer post-op here. From the front view, you don't see much. Oh my gosh. Oh, there's the talk. There he is from the side view. You know, this guy couldn't be happier, and takes an hour maybe to do this in the office. Here's another gentleman. This is even easier because mostly for this guy it's just skin, but we still do the same steps. This is a woman who'd had a facelift many years before. She was in her 70s, didn't want another facelift. but had a significant amount of redundant skin there, and this is a scar from below. I think the scar is more forgiving in men than women for a number of reasons. The major one being that most of the incision is kind of hidden under the shadow of the mandible, which is obviously larger in a man. But it can work for a woman too, but I don't do many. And then this is the last thing I do frequently in the office that would probably be a less good fit in a general ENT practice, but maybe not. I mean, everybody in this room has got the skill to do this. So as we age, the cutaneous part of our lip elongates. And often with facelifting, we're talking about lip lifting. It's really a nice adjunct to that procedure. But I see a fair number of younger people who come in who feel like their upper lip just doesn't fit their face. I'm super conservative in this operation because, like an alar base reduction, there's no going back. You know, you can always take a little more later, but if you do too much, it can look really funny. So I apologize for this not so great photo, but you can see where the incision kind of falls along. It goes up into the vestibule just a little bit there. When you do this excision of this skin, it tends to bleed a fair amount, and the temptation is to really go at it with cautery to stop the bleeding. I'm not so aggressive with that because I think if you cauterize this tissue less and you treat it gently, the incisions are going to heal better. So often we'll just hold pressure for a few minutes. I don't do much undermining after the skin's been excised, but I do spend a long time repairing it because you want this incision to look absolutely as good as it can. There she is repaired on the table. You can see how the upper lip is everted. This is a young woman who came in who just felt like her upper lip, cutaneous upper lip, was longer and she wanted a little more show of the vermilion. And that's a close-up of the scar. You know, if placed well and not closed under a lot of tension, it heals extremely well. That's all I have. Thank you for your time.
Thank you so much, Dr. Olson. I think you know, a lot of pearls in there that can be applied to any sort of in-office procedures, not just facial plastics. So next up, we have Dr. Amar Miglani. So Dr. Miglani is actually a rhinologist by trade. He's up at Mayo Clinic in Phoenix as well. And we actually go back to our old days in Charleston, South Carolina, and I heard that Dr. Miglani had a special interest in endoscopic septal perforation repair, which is, I think, is something that is a very challenging surgery. And so I was really excited to hear about his techniques. So without further ado, here's Dr. Miglani.
Thank you, David, for having me here. Thank you. Just by a brief show of hands, how many people have closed 5 of these? 10? That's really great. Well, I don't have any financial disclosures. My only disclosure is a lot of what I'm going to discuss is how I and how we at Mayo Clinic in Arizona approach septal perforation repair. It's not the only way to close these. It may not be the best way to close these, but what I hope to impress upon you is that it's a reliable method. But I'm curious at the end to hear your guys' comments because I think this is a very challenging condition, and there's a lot that we can still learn about it. So I'll go over the general approach to perforation treatment. I'll review how I repair these, and then I'll finish off by going over some of the perforation closure and symptom outcomes. So this is what we're taught. Start conservative, and if these conservative options fail, then you can consider surgical closure. But I think there's a growing body of evidence that shows that these can be closed successfully. And you can imagine a patient that comes in, you stop their Flonase, you put them on saline gels, and you do that for several months, maybe a year, maybe longer, and they continue to crust. You try out a prosthetic button. It doesn't really fit that well. Patients don't like it. And by that time, the perforation has grown in size. And what's happened is a perforation that was easily managed is now a lot more challenging to close. And so frequently in our practice, for a symptomatic perforation, we jump straight to closure. This is a busy slide. It's always important to remember, you're not just closing a perforation, but you're treating a nose that happens to have a perforation. And there are so many variables you need to take into account. Has there been prior septal surgery? If so, how much cartilage is present? If it's just mucosa on mucosa, it's going to make your dissection a lot more challenging. Are there septal deformities present? Are you going to address those because they're contributing to patient's nasal congestion? These factors can impair the ability of the repair to heal. And then, are there concomitant conditions that you need to treat? Do they have valve dysfunction? Are there nasal deformities? I'm a rhinologist, so I always think about sinusitis. These patients always have crusting and thick nasal discharge and congestion, so I routinely get a CT scan, and not infrequently I find sinus disease. And then, what does the mucosa look like? Here you can see a picture of lots of granulation. Frequently there can be scarring at the margin that collects crusts and that contributes to patient symptoms. How do you manage that? Do you resect it? If you resect it, you make the perforation larger, and you've turned the procedure into a more challenging case. So size is a big factor. A few comments on size. I see this all the time. People say 1 centimeter perforation, but that's inaccurate. If you look closely at these, 95% of perforations, they're elliptical, and there's 2 dimensions. They're usually longer in an anterior-posterior direction than they are tall, and that has implications for where you're going to harvest mucosa. If it's a tall perforation approaching the dorsum, then you may not want to incorporate mucosa above the perforation. The other important point is what's more important than the actual size of the perforation is the relative size. It can be harder to close this perforation in this nose than it can to close this perforation in a very large nose where there's lots of healthy mucosa around. Just briefly, these are the options for repair. Inferior turbinate flaps, people use them briefly. They had a lower success rate, probably 60 to 70%. And then you got this bridge of tissue traversing the nasal cavity, which could theoretically contribute to nasal congestion. That's fallen out of favor. Labial buccal flaps were used briefly. Substrate grafts, these are definitely easier. You basically elevate the mucosa and you slide in a substrate, and then you hope that the mucosa grows over the substrate. The one that's most popular now is the temporoparietal fascia wrapped around a PDS plate. I think the big question is how big of a perforation can you close with this technique? At what point does that substrate graft break down before mucosa can grow over it entirely? And then the one that's dominated the perforation literature is nasal mucosal flaps. In my mind, that's the most physiologic. And this is a little bit of a dated study. This is from 2012. But what it showed was that, sure, larger perforations had a lower success rate when you attempted closure, but bilateral mucosal flaps improve your closure rates, and use of an interposition graft also trended towards improved outcomes. I just wanted to acknowledge my mentor, Stephen Bansberg. He's the one I credit most of my perforation experience to. And I spoke with him a few weeks ago, and he told me that the first 30 perforations he did, he had to open the nose up. But with time, he gained more experience, and now he's done over 400 of these just endonasally. And I think what's further assisted our ability to close these endonasally is the use of the endoscope. But I think the endoscope is a useful tool, but you can't only use the endoscope to repair these. It's an adjunct to loopes in a speculum, because there are certain things you can do with loopes in a speculum. Suturing in the nose is a lot easier. Working above the swell body, if you're making cuts, it's a lot easier than using an endoscope. But I do think the endoscope's useful for mucoperichondrial elevation, particularly posteriorly in the nasal cavity. making mucosal cuts along the floor, and then developing your flaps. So how do we do this? For a right-handed surgeon, we make a right hemitransfixion incision, but we start our elevation on the left side. We elevate through the perforation and about 2 centimeters beyond the perforation, and then up to the level of the upper lateral cartilage, and then down onto the floor out to the inferior meatus. So you're really trying to get a wide elevation, and this is what that looks like. So here's a moderate-sized perforation, and we first elevate to the margin of the perforation. We contour the margin, we elevate above, and then we can incise the perforation margin with a 15 blade. This exposes the posterior perforation margin. And then you can score the posterior perforation margin with a 15 blade. And I find endoscopic elevation at this point a lot more helpful. Key is you want to make sure you get down all the way to the floor and you free up the nasopalatine bundle. So it's really a wide elevation. On the right side, we do something similar. We elevate through the perforation 2 centimeters beyond and down onto the floor of the nose. Here we don't elevate above the perforation because our flap design doesn't incorporate that mucosa, and we want to limit exposing the superior cartilage bilaterally. So this is what that looks like. Here we're elevating the right nasal cavity mucosa, the right septal mucosa, and here the 3 layers have been separated, and you can see the nasopalatine bundles have been freed up on both sides. And this just illustrates how wide that elevation is all the way down to the floor. So next we develop a superior bipedical flap. We create a cut along the superior septum above the perforation. And I find this is best done with a speculum and a headlight and a 15 blade. You can see here that we've advanced the flap down and it's really closing this perforation margin. And then the next step is to create a cut along the nasal floor here and extend it posteriorly within the inferior meatus. So we start by making a little mucosal window on the piriform aperture. You can elevate the mucosa within the inferior meatus, and that's what this image shows, that mucosa elevated. And then using scissors, you can incise the mucosa along the nasal floor. I actually find this part to be done a lot easier with an endoscope and a needle tip cautery. But here you can see the flap laxity. Now that the cuts have been made, you can almost pull this thing closed. And at this point, we advance flaps and we throw fluorochromic sutures on a P3 needle. I bend the needle about 2/3 of the way back. I like to use a Castro Viejo. You don't want something that's going to apply a lot of torque because that can tear your septal mucosa, so I find that the Castro Viejo works really well. All you need is about 3 or 4 sutures to get this thing closed. And this is what it looks like. Here you can see the mucosa has been advanced. There's a bare area of cartilage up here. Sometimes you get a little dog ear, but that flattens out nicely. And what you want to see from the right nasal cavity is the defect completely closed. This is the suture line. And then on the right side, we extend our hemitransfixion incision along the floor of the nose, and I advance that to oppose the suture line. Again, this is a part of the procedure that I routinely do with an endoscope. Here that mucosa has been freed and then advanced to oppose the suture line. The last step is to introduce an interposition graft within the septal space. The workhorse is temporalis fascia for me. Another good option if you're doing valve surgery is auricular perichondrium. You can harvest your graft and then peel off the auricular perichondrium. And that just slides within the septal space. And this is what it looks like. This is a typical piece of temporalis fascia that we would use, and this is it sitting within the septal space. This illustration highlights the final repairs. So on the left side, you have superior flap and an inferior flap that's been advanced to close the perforation. There's an interposition graft sitting within the septal space, and there's an inferior bipedical flap that opposes the temporalis fascia interposition graft and the suture line. And then the silastic sheeting stays in for 2 weeks to protect the donor site and facilitate remucosalization. So those were for moderate-sized perforations, but for very large ones, there are various options. There's the upper lateral cartilage mucosal flap, which basically involves extending your superior flap and taking mucosa from the undersurface of the upper lateral cartilage. There are pedicle nasal mucosal flaps. These rely on nasal floor mucosa, and I'll go over the anterior ethmoid shortly. The pericranial flap, that's been reported intermittently here and there for subtotal perforations. We tried 2 and they failed, so we've really moved away from that. Perforation, extension, and posterior margin repair, those are really reserved as a last resort effort for subtotal perforations. This is the upper lateral cartilage mucosal flap. So basically, by incorporating an intercartilaginous incision into your superior flap, you can get an extra centimeter of mucosa. And so here's a large perforation. You can see it approaches the dorsum. Not a lot of mucosa above the perforation, but by peeling the mucosa, making it an intercartilaginous incision and elevating this mucosa off the upper lateral cartilage, you can get quite a bit of mucosa for your superior flap. And you can see the thick swell body mucosa juxtaposed against this thin upper lateral cartilage mucosa. I like the anterior ethmoid artery flap. It's not a very challenging flap to elevate. It incorporates nasal floor mucosa that you can advance to close these defects. And so this is a case here. Patient had a 1 centimeter perforation. There's all this scarring around the perforation margin that was collecting crusting and contributing to his symptoms, and I wanted to excise that. But before doing that, I elevated anterior ethmoid artery flap. And this is a good example of where endoscopes can be useful. So I palpated hard-soft palate junction, and I'm just marking my floor cut right now. And then I start making my posterior cut at the head of the middle turbinate, along the posterior septum, down to the floor. And then you can bring this cut anteriorly along the nasal floor and connect it to your posterior perforation margin here. And then you make your anterior limb cut. And here you can see your posterior cut, anterior cut, and floor cut. Not very challenging, and the endoscope is really nice for making these incisions. So to elevate this, you make sure you're freed up posteriorly all along your posterior cut, and then also laterally. And this way, when you elevate the flap in an anterior to posterior direction, there's a clear separation point. So this is the flap elevated and advanced, and you can see that there's just wide defect coverage. So at this point, I trimmed that surrounding mucosa and I inset the flap. And this is at 3 weeks, I took the silastic sheeting out. It's healed up nicely. The donor site's mucosalized already. That swelling will settle down. This is the other side with the standard bipedical flap technique. Also, you can see a few sutures, but overall, that's progressing well and healing well. And his symptoms improved. So that's another thing that we've been doing. This is a patient-reported outcome measure that's been validated for septal perforations, and his symptoms improved at 3 months. Big credit again to Dr. Stephen Bansberg. So between 1991 and 2021, we've done 430 of these repairs, all through an endonasal approach. Success rates 96% overall and 92% for ones that are larger than 1.5 centimeters in vertical dimension. And about 10% of these patients had concomitant valve surgery or sinus surgery. Overall, low complication rate. Sometimes patients will complain of some palate paresthesia, but that's usually temporary. There is prolonged mucosal swelling and congestion. So in contrast to your septoplasty patients where you see them back at 1 week, you take the splints out, 50% of them are breathing well. That's not the case here. This is really 2 months of feeling pretty miserable, feeling stuffy. There's lots of raw area that still needs to heal within the nasal cavity. And by tracking these symptoms, we found that usually their symptom benefit seems to plateau somewhere between 3 and 6 months. So how do they look back on this experience? 2 months is a long time to feel miserable. Well, we asked them to rate this is an instrument which kind of answers that question, and it actually compares pretty favorably to rhinoplasty procedures and septoplasty and FES. So overall, they're pleased with their experience, and there's definite symptom improvement that they experience as well. This is the instrument that some of my colleagues developed. It basically took the nose score and we added a few questions that were specific to septal perforations, so crusting in the nose, whistling in the nose, bleeding, and that's something you can give to patients at baseline and post-op. So in conclusion, just remember, you're not treating a perforation, you're treating a nose. There are various factors that you need to take into account: the quality of the mucosa, if there's a deviation present, if there's valve issues or sinusitis. I hope I've impressed upon you that mucosal flap closure using an interposition graft can achieve reliable high success rates, and the endoscope is really a nice tool to help facilitate closing these endonasally. And then we know that we can close these. The next step is to figure out how symptoms progress in the post-op setting, and an easy way to track symptom improvement is with an instrument like the nose perf score, something that you can give pre-op, and you can track how they do over time post-operatively. That's all I have. Thank you so much for your time.
Dr. Maglani, I wish I had heard that talk sooner. Thank you for that. That was awesome. So next up, we have Dr. Janae Ostrom. Dr. Ostrom is a facial plastic and reconstructive surgeon from here in town. She practices at Tucson ENT. She is actually a former graduate of this program, and we actually met on the interview trail for fellowship, which, believe it or not, was almost 4 years ago now. But this was pre-pandemic, so it feels like we've known each other for longer. But Dr. Ostrom is going to talk about less invasive options for addressing the nasal side wall.
Hello, thank you guys for having me today. I think I was at the very first Tucson ENT as a second-year resident when I was in my residency here, so it's really nice to be invited back as a speaker. My name is Janae Ostrom. I'm in private practice here in Tucson at Tucson Ear, Nose, and Throat. I also go to the VA for facial plastics cases once a month, and I participate in the trauma call coverage at the university and get to work with the residents. So it's great to be with you here today. I have no disclosures. This is more for the residents, so we're going to be talking a lot about the nasal valves today. Just as a review, the nasal valves account for a significant amount of the airway resistance. Specifically, the internal nasal valve is attributed to 50% of the nasal resistance for patients. The medial border is the nasal septum, lateral border, the caudal border, the upper lateral cartilage, and the inferior border being the head of the inferior turbinate. Dynamic nasal valve collapse, both internal and external, are often under-recognized and undertreated and do contribute to a very significant amount of nasal obstruction for patients. The external nasal valve is the region caudal to the internal nasal valve. As you can see in this diagram, it consists mainly of the aperture of the nose or the nostril. So what exactly is the problem? As you know, nasal obstruction comes in many different flavors, from septal deviations to inferior turbinate hypertrophy, and anywhere in between, any combination of all of the above. This patient has an obvious external nasal valve collapse. This is easy to identify, but you may not know how to treat this. So when you come across a patient like this, it's good to be aware of your options and where to send them if it's out of your scope. So the problem with nasal obstruction, this was a study conducted of about 2,000 patients in 2018, and these were patients all across the US. They were presenting to their ENTs for sinonasal symptoms. The patients were asked to complete nose scores and then were examined thoroughly by the practitioner. Of these patients, 76 were found to have septal deviations, 72% inferior turbinate hypertrophy, and 67% were found to have nasal valve collapse. What I found interesting about this study was 82% of patients with severe or extreme nose scores, which are the two highest categories of nose scores, had previous septoplasty and or turbinate reduction surgery, highlighting the importance of the nasal valves in their breathing issues. If you're not familiar with the nose score, this is a very important tool in my practice for tracking my own outcomes. It's a brief survey for patients while they're waiting for you to see them in clinic. It's validated. It was developed in 2004, and it's very reliable. It's been used in many studies published on nasal obstruction. And simply, the patients report their response on 5 different questions. They rate their scores from 0 to 4. The score is tallied and multiplied by 5 to give you a classification. So what are our options for the nasal valves? Traditionally, we have 2 options. We have dilators and strips, which patients can apply as needed. In my experience, patients become frustrated with these options very quickly. The strips tend to irritate the skin and fall off, and the dilators are cumbersome and kind of an issue for them to use. And then we have functional rhinoplasty. But there are some options now that can be available to patients that are between these 2 options. So what are these alternatives? And I promise I have no affiliation with these companies or devices. And as a facial plastic surgeon, we're trained to do all these fancy maneuvers to improve the nasal valves for patients. And I'm always skeptical when devices come on the market and tend to undersell them to patients, although I do present them as options. The first one that I was introduced to actually in residency are the absorbable nasal implants. These were approved in 2016. You may or may not be using them in your practice, but I think they are an important thing to consider implementing into your practice. They're approved for use if supported the upper lateral and lower lateral cartilages. They're a blend of L-lactide and D-lactide, which is similar to Vicryl sutures. They degrade over the course of about 18 months, and they're thought to induce collagen formation in the nasal sidewall over time. Do these actually work? The answer seems to be yes, based on the studies available today. This is a single-blinded randomized control trial that was published in 2019. It was obtained on 137 patients. They recorded a responder rate, which is an improvement in nose score of at least 1 classification or 20% in sinonasal symptoms. They found that 82.5% of patients treated in the treatment arm were responders, compared to 54.7% in the placebo arm. This translates to about a reduction in 42.4 points in the nose score compared to 22 points in the placebo arm. Interestingly, they also analyzed a patient's visual analog scale, which has been strongly correlated to nasal rhinometry, which is not readily available in my practice. I don't think anybody's practice. But when they looked at the visual analog scales for these patients, at the 1-month follow-up, the treatment arm had improved on their visual analog scale by about 30 points. At 3 months, they had continued improvement to negative 39 points. Whereas the placebo arm, how they had initially had an improvement of about 21 points, actually returned closer to baseline with only a negative 13-point improvement. We do finally have some longish-term data available for these implants. This was recently published in 2021, and this took patients with all severe and extreme nose scores, and they had various treatment modalities. So the orange column is the one I'm most interested in. These were the implant-only group, and you can see from a baseline of around 80, nose scores improved drastically at the 1-month follow-up and were consistently improved across all follow-up time points out to 24 months. Looking at responder rate alone in these patients, which again is greater than or equal to 1 nose category or greater than equal to 20% reduction in nose scores, we see the implant-only group responder rate of 90% at 1 month, and this was stable out to 24 months at around 90% as well. But how does this compare to rhinoplasty? Functional rhinoplasty is thought to be the gold standard for nasal valve repair. However, a meta-analysis that focused on lateral nasal airway surgery found that at 3 months and greater, patients who underwent lateral nasal surgery had a 45-point reduction in their nose score on average at the 3+ month mark. This is compared to 42.4% for our implant group at the 3-month mark. So very comparable results if the patients are chosen appropriately. These implants do have some limitations. Specifically, you need to be very careful of patients who've had prior rhinoplasty surgery. Reductive rhinoplasty usually involves cartilage reduction, and these patients may no longer have enough cartilage in the lateral nasal sidewall to support the implant. Likewise, osteotomies or otherwise narrow nasal bones will have limited effectiveness when the implant is placed. Also, we need to be aware of the placebo effect. If you recall from my previous slides, there was an improvement in nasal valve symptoms even in the placebo group, and this has to do with how the device is presented to patients. So like I said, I tend to undersell these to patients. I tell them, you know, studies have shown they've been 90% effective in reducing your obstruction, and I caution them that these are, you know, studies that want to support the sale of these devices. But I've been pleasantly surprised, and anecdotally, I would say about 75% of my patients come back and are very happy with their results. There are some adverse events to be aware of. Implant retrieval about 4% of the time when the implant is not correctly placed. Part of it can extrude into the nasal cavity. Pain, foreign body sensations, swelling, inflammation, skin puncture, and of course vasovagal response. And again, we only have outcomes for these up to 24 months as of now. The other device, which I'm less familiar with, but is also available, is a bipolar temperature-controlled device that is used in clinic to treat the internal nasal valves. The treatment site is over the edge of the upper lateral cartilage, and 3 non-overlapping sites on the lateral nasal valve are treated. Mechanism of action is implied from studies done elsewhere in the body with radiofrequency. This is a study that was done in the face with treatment radiofrequency from the Academy of Dermatology. As you can see in the top slide, these are bright field microscopy. The collagen is stained with picrocereus red at baseline, which is prior to treatment. You see there's organized collagen under the surface of the skin. By the end of treatment, this has reorganized and some new collagen has been regenerated, and then post-treatment, there's a significant amount of increased collagen abundance. The bottom line slide is yellow-orange birefringence under polarized light, and the yellow reflects newly synthesized collagen, and you can see at the 3-month mark, there's an abundance of new collagen generated. We have new 2-year data for this device as well. All the patients in this study had a nose score greater than 60. Pre-treatment average was around 80. And at the 6-month mark, these patients had a nose score of 55.9, so a statistically significant improvement in their obstructive symptoms. This was stable at the 24 mark, maybe even slightly improved, with nose scores averaging around 53.3. Graphically, you can see on the left in teal, this was the baseline average of 80, and it dropped down to 35 at the 1-month mark and was consistent all the way out to 24 months. We have no randomized studies as of yet on this device, so it's hard to tell how much of an impact placebo effect has on the study's outcomes. And also, the outcomes measured rely heavily on the patient's response, so there's no objective measures like rhinometry to tell us if these results are in fact significant. Some pearls that I have for you if you're going to implement these procedures into your clinic. There's a slight learning curve to placement of the implants. Patient comfort is going to be very important. You want to be well versed with how to deploy the implant, how to load the implant prior to the patient coming into your clinic. You don't want it to seem like it's your first time or they get very anxious, and that's when things go poorly. Patient comfort is key. I personally only use local. Some of my colleagues have employed anxiolytics, or newer on the market is the MKO lozenge. I'm not sure if you guys are using that, but I find that numbing the patient is adequate. Positioning and use of a double-pronged skin hook for counter tension is very important as well. You want to be really careful with these 2 patients. I've pulled some images. The top image is a patient with recurvature of the lower lateral cartilage into the nasal airway. The device is not strong enough to support this cartilage. This patient needs an open functional rhinoplasty. Same with the patient in the below image. This patient has malpositioned lower lateral cartilages, and again, he's not a good candidate for placement of this device. The radiofrequency device, however, is very straightforward. It's only helpful with the internal nasal valve. The handpiece that it comes with, you can apply multiple pulses of electricity. So on your way out of the nose, you can easily treat the inferior turbinate if they have inferior turbinate hypertrophy as well. So a couple of takeaways. New technology is available, even for me, a skeptic, a facial plastic surgeon. The in-office procedures that are available to you do not preclude the patient from future functional rhinoplasty if necessary. They are designed for in-office use. Use in the OR often does not reimburse well. So be sure that you do your research before taking a patient to the OR for these procedures. Patient selection is very important and relies heavily on the surgeon's ability to diagnose the problem correctly. And please remember to examine your patients thoroughly. If there's any doubt about what is causing the obstruction, scope the candidate or the patient. I recently had a patient come to my clinic who had had 2 previous functional rhinoplasty surgeries by a general plastic surgeon who isn't familiar with endoscopes. And something was off, so I scoped him. Something was very off, so I got a CT scan, and he was a 64-year-old man with unilateral choanal atresia. So just a reminder, examine your patients. And that's all I have. Thank you.
Dr. Ostrom, thanks for shedding light on a hot topic and a hotly contested topic. I have a feeling you're going to get questions, and so we'll take questions at the very end of the session. All right, so I have the pleasure of closing us out for today. It's almost noon, so people are probably getting hungry, which is great because I'm talking about ribs. All right. So specifically what I wanted to talk about today is kind of one of the controversies in facial plastics and in rhinoplasty, and that's the use of autologous versus cadaveric rib cartilage for grafting in the nose. And so we all know that there are multiple sources for grafting and implants and rhinoplasty. The most common, of course, is septal cartilage. It's something that's readily available, doesn't require a second donor site. And septal cartilage has, a lot of times, the ideal consistency and rigidity for a lot of the grafts that we use in rhinoplasty. This is made of hyaline cartilage. The issue is that, of course, every now and then, patients may not have sufficient septal cartilage for what you need to do. They may have absent septal cartilage if they've had a previous septoplasty, or if they've had a really bad trauma, their septum can be so bent out of shape that it's just frankly not usable. So another option is auricular cartilage. This is kind of a second line go-to. It does require a second donor site, but these are relatively accessible and easy to harvest. There's minimal donor site morbidity. Ear cartilage is a different type of cartilage. It's elastic cartilage, and so it's much softer and it's inherently curved, so it's not ideal for some of the structural grafting that we do. More rarely, split calvarial bone can be used, and so bone provides obviously a lot of stability and rigidity, and that can be great if you're making big changes to the nose. But patients also have a really tough time getting used to having bone in their nose. It feels exactly how you would imagine, a super hard piece of bone, and it's also very difficult to carve, and so those are some important limitations. And then lastly, we have alloplastic implants, which are theoretically available in abundance. They come in all different shapes and sizes, and so they sound really great on paper. The issue with alloplast is that they can frequently cause tissue reactions and also have a high risk of extrusion and infection that are much higher than some of the other graft options that we've listed here. And so that really limits their use as well. And of course, the star of the show is costal cartilage. So rib cartilage is typically harvested through an incision on the lower medial chest. Usually we go for the 6th or 7th rib, and once we go through the skin and the muscle, we make a perichondrial incision, and then we perform a subperichondrial dissection. Sometimes you may even choose to leave a little bit of the rib cartilage on the deep aspect behind in order to protect the pleura deep to the rib. And so once you've harvested the rib, you typically get a segment that's usually about 3 to 5 centimeters. It's shaped like this. And this is also hyaline cartilage, similar to the septum. And so rib is great when you need a lot of cartilage and you're putting in a lot of grafts or really rebuilding the nose. And so it's ideal for surgeries like revision rhinoplasties, as well as saddle nose deformity repair, to name a few examples. And so this is an example of a patient who unfortunately had a really protracted bout with invasive fungal sinusitis that ended up giving her a very large septal defect as well as a palatal defect that was affecting her speech and her ability to eat and drink. But even in light of all that, the thing that bothered her the most was her physical deformity, her saddle nose, because it just impacted her self-perception and how she looked at herself in the mirror every day. And so what we ended up doing is harvesting a piece of rib cartilage. We carved part of that into a dorsal augmentation graft, and we put a notch in one end so that we could fit in a caudal septal replacement graft in a tongue and groove fashion. We trimmed this to the appropriate length to give the nose the projection that we wanted, and then we resuspended her lower lateral cartilages, which were actually really nice and intact to that whole construct. And so you can see that we gave her a much improved dorsal contour on profile and nasal projection, and then on frontal view as well, her tip contour is much better. Her brow tip aesthetic line is restored. And she was eventually really happy with the result, but I remember seeing her 1 week post-op, and she told me, Doc, if you had told me that this would hurt so bad, the rib would hurt so bad, I probably would not have done this. And she eventually, changed her mind and was ultimately very happy. But that post-operative pain in the first week was no joke. And so there are drawbacks to harvesting autologous costal cartilage. It obviously increases your operative time. As I mentioned, significantly increased post-operative pain and recovery time. I always, when I'm counseling patients on potential rib harvest, I always say the rib hurts way more than the ear, which hurts more than the nose, which actually doesn't hurt too much at all in comparison. And so, this is something I really try to prepare patients for. Patients who have had rib fractures in the past kind of liken the pain to another rib fracture. And then, of course, there's a scar that's visible on the chest. In female patients, we camouflage, hide part of the scar underneath the inframammary crease, but part of it is still visible. And of course, with patients with darker skin, there's an increased risk of hypertrophic scar and keloid. There's that dreaded risk of pneumothorax, which is rare, but can happen. I always tell patients about that preoperatively. And then there's the issue of ossification. So as we age, all of our rib cartilage naturally becomes more and more ossified to the point that it's really unusable at a certain point for grafting purposes. So if you're trying to carve it or pass a suture needle through it, I've had instances where I've taken a piece of rib cartilage and it's kind of speckled with bone in between all the cartilage, and you just can't really sew it to anything. And this can happen at different ages as well. So typically, it's only seen in more commonly in older adults, but I have had patients as young as in their 20s and 30s have significant ossification that really made grafting a huge pain. And so there's another option to kind of that bypasses some of those disadvantages, and that's a radiated homologous costal cartilage, which I'll just refer to as cadaveric rib for short. And so this is cadaveric, or it's rib cartilage that's harvested typically from young, healthy cadavers. And so before any of that significant ossification has taken place, it's screened for viruses, and it's also irradiated to destroy all of the donor cells and antigens that could potentially create an immune response. So it comes in this really nice packaging, and it's usually of a sufficient length. So all of that sounds great, but throughout my entire training, I've been sort of it's been drilled into me that there's this idea that irradiated homologous costal cartilage, cadaveric rib, is just always going to be inferior to taking a patient's own rib. And the concerns that are raised, of course, are with warping, with potential resorption of the cartilage over time, and increased rates of infection. And even the earlier data that came out, looking at complication rates with cadaveric rib, showed that the warping and the infection wasn't necessarily going to happen at an increased rate. But the resorption was still a real concern. And in fact, some of the preeminent rhinoplasty surgeons in our field have kind of come out and decried cadaveric rib grafts because of the issue of resorption. And so, what am I to think as a fairly newly minted surgeon who's trying to decide what graft to use in patients' noses? How can I potentially justify using a graft that, although it bypasses a lot of the problems of autologous rib cartilage harvesting, might dissolve away in a few decades? And so I really wanted to take a closer look at the data. And surprisingly, there's a lot of studies reporting complication rates for cadaveric rib or for autologous rib. But there's really very few studies that offer direct comparisons between the two. And in fact, I could only find 3 studies. And so here's one of them. This is a study done out of Korea. It's a retrospective series of 63 patients with a mean follow-up of about 2 years. And they found that notable resorption occurred more frequently in the cadaveric rib group, about 10 times more often than in the autologous rib group. And so that's kind of a big statement. So 30% compared to 3%. But there were a few important limitations to this paper. And so one limitation, of course, was a smaller sample size. So if you look at the actual number of infections, number of resorptions, it was 6 compared to 2. And the outcome measures for this study were also totally subjective. So resorption was actually measured subjectively by the patients and the surgeons as a change in appearance. But even considering that, these are some hard numbers to ignore. And the authors of this paper offered some explanations as to why there was such a big discrepancy. So they actually did some histologic studies as part of this study, looking at staining for collagen and proteoglycans. And their mindset was, their thought was, of course it makes sense that cadaveric cartilage is going to be resorbed more frequently because it's been irradiated, you've killed all the cells, there's nothing alive in there, and so of course the body is going to resorb it. And so they did find decreased concentration of proteoglycans, which is this Mason trichrome staining here. So the blue is supposed to show the proteoglycans, and also Alshin blue staining for collagen. There's significantly less uniformity and overall less density of collagen in cadaveric rib as well. How mechanistically this may translate to increased resorption is unclear, but they offered up these histological differences that they found. So again, one of the drawbacks of this study was the small sample size. So then this next study is actually the biggest study that we have to date. It's the biggest series with the longest follow-up time, looking at both cadaveric rib, homologous rib, as well as autologous rib. So this was a series of 357 patients, and they broke that down to over 1,000 cadaveric rib grafts, and then 218 varied autologous rib grafts, which were autologous grafts, which were not necessarily rib. So they included auricular cartilage as well as septal cartilage in this group. The mean follow-up was much longer. It was 13.5 years. And so in this study, they actually looked at rates of warping, infection, and they broke down resorption to that associated with infection and not associated with infection, as well as mobility and extrusion. And to summarize, we don't have to go through all the numbers in detail. They found that the complication rates, especially the total number of resorptions, which was much lower than what was reported in the previous study. And in fact, the total number of resorptions they have here is about 1%. One of the criticisms of this is that they counted the number of resorptions out of the total number of grafts as opposed to the total number of patients, which underestimates the resorption rate. But even if you look at the number of resorptions per patient, so it's about 10 out of the 350 or so, it ends up actually being about 3%, which is the same rate of resorption reported for autologous rib grafts in the previous study. So a little bit more reassuring. And in fact, the overall resorption rate for this study was found to be, for cadaveric rib, was found to be lower than for autologous cartilage. So kind of a reversal of findings. But the caveat there is the few cases of resorption that they found in autologous grafts actually happened in septal cartilage and auricular cartilage. So it's not really a fair direct comparison of rib to rib. And that's kind of the issue with a lot of these studies is, again, they look at either, there are surgeons who either do a lot of autologous rib grafting or a lot of cadaveric rib grafting. And there's complication rates reported for each, but not necessarily in comparison. So if only there was a way we could just aggregate all that data together into one study and look at those numbers. And so that's exactly what this study did. So this was actually done in 2019 by Peter Villa, who's actually a contemporary of me and Janae's. And so he performed a meta-analysis looking at 28 of these studies that were done, looking at either autologous or homologous rib cartilage, and then looked at a bunch of different outcomes. So this is an example of one of the outcomes, again, which is resorption. And so out of all these 28 studies, you can see that the aggregate data doesn't reach the threshold for 95% confidence interval. And so they did not find that there was significantly more resorption in cadaveric rib compared to autologous rib. And in fact, when they looked at comparison between autologous cartilage, autologous rib with cadaveric and something called pseudoplast, which is similar to cadaveric rib, but it's chemically treated in a different way. There were no differences in warping, resorption, contour irregularity, infection, or the rate of revision surgery. And so this is probably the most robust study that we have to date looking at comparison between the two types of rib cartilage. But you have to keep in mind, this is still all retrospective data, right? So it doesn't get around the fact that patients who get autologous rib grafts versus patients who get cadaveric rib grafts are going to be inherently different, as are the surgeons who perform those techniques and the indications for using one graft over the other. And so we're probably never going to get that randomized controlled trial where we say, hey, we're going to either use your rib cartilage to put in your nose or someone else's rib cartilage and put it in your nose. And we don't really know which one we're going to do. We're going to flip a coin and find out. And so we kind of have to take the data for what it is. I wanted to put this in as well. So I was curious what the cost of these cadaveric rib cartilage grafts are. And so for at least our vendor that we use in our hospital, a 30 millimeter. So a 3 centimeter segment costs $500 and a 6 centimeter segment costs $600, which is actually a lot cheaper than I thought it would be. And if you take into account the time that it takes to harvest someone's rib, that OR time is going to be at least comparable, if not more expensive. So what's the verdict after all this? And I think the unsatisfying answer is we don't know for sure, but I think there's enough data out there to at least justify the use of a cadaveric rib in patients that are appropriate for it. And so on that note, I actually wanted to turn it over to the panel to see what individual surgeon preferences are in terms of, how you choose whether or not to use cadaveric versus autologous rib, and if you prefer one over the other.
I'm not going to be able to pull this out of the stand apparently, so it was a wonderful talk, and I think you've asked all the questions that I certainly know I've asked over the years about these. I do both autologous and donor cartilages. For people that are under about 30, I strongly recommend they use autologous. For people that are over 50, I strongly recommend they don't use autologous. Because my experience is that those that insist I try harvesting their own is that I throw them in the trash because they're just solid bone by then. And then everybody in between, I present that exact same data that you just shared and let them choose the pathway that's best for them, and I'll support them. But I have to say I've had enough problems with, down in even 30s and 20s having really significant ossification. I still always consent to know, if you have horrible quality cartilage, can I use cadaveric donor? Because I am afraid of the day that I get stuck and don't know what their preference would be. And the only thing I actually had to add was that after I found out what the donor cartilages cost, I went back and ran all of my numbers to find out how much I made when I harvested rib. So the average across something like 30 of my rib grafts was basically that I make $550, which is not worth the OR time or the paranoia of worrying that someone is going to have a chest problem, I've decided. But I do use the liposomal bupivacaine. It seems to really help with tolerance.
I also give patients the choice, so I fully counsel them on the data available. I find that older patients are skeptical of having donor ribs anyway, and my preference is to use a donated rib on them for the calcification issue. My cutoff is usually 50 as well. I also younger patients, I try to figure out if they're a soft grape or a firm grape, meaning do they have good or bad protoplasm for doing a chest wall surgery. If I feel like they're not going to tolerate the procedure well, I push really hard for the donor rib. The only thing I would say is that there's a very severe shortage right now for the cadaveric rib, so I've talked more patients into using their own rib because I just don't know when I'm going to get any in stock. It's been almost like 7 months since I've been able to get a donor rib, so that is one thing that's kind of weighing into the decision making currently. But I don't find that there's a difference in outcomes from what I use as long as the rib's not calcified.
So I don't harvest rib often at all. I'm fortunate in that the majority of my cosmetic rhinoplasty patients are primary cases. If I'm going to take rib, I guess I'm going to take the patient's rib. Again, it's been a while. I didn't do any rib harvesting last year. I did well over 100 rhinoplasties last year. What's interesting to me is I saw a number of patients over this past year that had rib and then were, still having issues, cosmetic or functional. Some of those patients still had septal cartilage that was part of the functional problem. A couple of them had nobody touched the septum, nobody touched the ear, and the problems were relatively straightforward. And they've come both, well, primarily out of plastic surgery people in town, and some from ENT surgeons in the state. And it sort of makes me wonder, like, well, what's driving the decision making that you would go to rib versus taking the stuff that's there in the field? And I think about over the past 10 to 15 years, people are really influential in our society, like Dean Toriumi and Rick Davis. In the nature of their practices, seeing horrible disasters where every easily accessible piece of cartilage is gone. So they're forced to do rib all the time, and they're really, really good at it. And I think when you're really, really good at it, you don't think twice, For me, I would go, oh, geez, rib, So, but it's this last study I was not aware of, the meta-analysis, it would make me think more about using that when it's available in the future. But again, I've been lucky in that I don't see a lot of patients where we can't do it some other way.
Great. Are there patients, certain patients or cases where you would say absolutely no cadaveric rib, draw a hard line? So things like,
I guess not.
there's people who are radiated or had previous infections, or do you think those are all still fair game?
I think they're all still fair game. My rheumatologists are really biased against it, and they really want my Wegner's patients to have autologous, and I really don't want to go into the chest wall of my Wegner's patients, so I try to get them before they get to talk too much to rheumatology and endocrinology are the ones that seem to have more bias, and sometimes we'll make it so it's harder for me to have an unbiased conversation, hopefully, about it.
No, I don't think so. Just like you discussed in the studies, there's no increased risk of infection in my experience or in the studies that I've read, so I'm okay with donor rib.
And so this last question is actually more from my curiosity. The way I counsel patients, I kind of tell them both options. I tell them the pros and the cons. And the truth is, there's this theoretical benefit of taking their own rib. But then there's this whole slew of potential risks, and it sounds terrible, like it sounds super painful, which it is. And so when I give patients the choice, at least in my practice, most of them actually will pick, I would say 3/4 of them will opt for cadaveric rib if it's needed. Now, for most of those patients, I don't end up needing it. But I was curious in your practices, Dr. Howard and Dr. Ostrom, because you counsel patients and you kind of give them the choice, what's the ratio, what's the percentage that you see that they'll choose?
I think that most of mine that are candidates for autologous, kind of, in my view, they usually choose autologous. However, a lot of the patients I treat are over 50. At Mayo, we pull kind of that particular patient group more often. And I have a tendency towards, this week was rhinoplasty number 5, rhinoplasty number 6 revision, and sometimes they've already had their own ribs harvested. And so I do still do a fair amount of donor.
Got it.
Yeah, like I said, I think the younger patients in my practice tend to opt towards using their own rib for some reason. I don't know if it's just that they haven't had a lot of surgical pain, so they're not afraid, or they don't like the idea of having a cadaver rib in their nose. But the older populations are more willing to accept the cadaver rib, in my experience, than the younger patients.
Great. That's wonderful. Thank you. So at this point, I'd like to open up the floor to any questions you have for any of our speakers today about their talks or otherwise. Dr. Miglani, do you want to come and grab a microphone? So the question is, it sounds like for this is a second septal perforation repair. There's concern that she might be redeveloping the perforation. Is there anything we can do to sort of minimize that? What can we do?
I think these issues are challenging, and when you mention that, I also think of just patients who have these chronic ulcers in the nose, and what's the best way to manage that. We've tried with some mixed success. I've done this before where I've debrided the obvious crust on the septum, and I've sutured in silastic sheeting just to cover it up for like 3 weeks. Some patients have done okay, and things have healed underneath, but probably a 50% continue down this pathway where they just continue to crust. And an option would be to debride some of that superficial mucosa that's unhealthy and rotate tissue from the floor via the anterior ethmoid artery flap to help reline that area before they break down, or you can just continue to observe, and if it reperforates, address it at that time.
The one other thing, I don't have any personal experience with this, but it's been an ongoing discussion, is the use of Trentol, which is a systemic agent. We use it for radiation ulcers in head and neck patients to get healing. And so there's discussion of its utilization. It's thought to kind of improve blood flow in these local devascularized, chronically dirty wounds. And you do about 4 weeks of treatment, reassess people. You know, certainly radiation ulcers, we usually see significant improvement. You can leave them on a little bit longer, and usually once healed, they stay healed. And so there's been discussion of application in head and neck facial plastics for some of our difficult to heal, especially dirty wounds like this, where there's this component both of decreased vascularity, maybe after surgery, maybe after other kind of insult, and then you add on the microbiomes that we deal with in the head and neck and these dirty mucosal surfaces. And there's certainly some subjective data to suggest it works. I certainly wouldn't hesitate, I guess, to consider or try it or run it by the patient personally. Trentol, it's a high-powered vitamin E, I believe, effectively.
Yes. So go ahead.
Sorry. So for my Latera patients who aren't happy, I make them wait at least a full year, and then I take them for an open functional rhinoplasty. I've only had a couple though. I think because my patient selection criteria are pretty strict. They have to have pretty minimal external nasal valve collapse and no other issues that need to go to the OR. If I'm taking them to the OR anyway for septoplasty, turbinates, then I just address the nasal valve surgically. Yeah, there is some scarring present, but it's not unmanageable. It's almost like a revision rhinoplasty.
All right, any other questions? I think if that's it, then we can probably break a little bit early for lunch. Thank you, everyone, for your attention. It's a pleasure. Thank you.